Hello, everyone, and welcome to our virtual on-demand back-to-school conference. My name is Angie May, and I'm honored to serve as the board chairperson for the Epilepsy Foundation of Michigan. I want to start by thanking each of you for joining us virtually today. It is an honor to serve the epilepsy community, and we hope that you leave today knowing that you are supported. As you may already know, there are around 3.4 million people living with active epilepsy in the United States, and almost 500,000 of these people are under the age of 17. We are also keenly aware that there are nearly 14,000 children in Michigan living with active epilepsy. This statistic is particularly powerful to me as my two daughters, Madison and Ashlyn, are living with an epilepsy diagnosis. Like so many of you watching today, I share in our collective vision of utilizing tools, resources, education, and support in order to overcome challenges and promote the success of our students living with epilepsy. This on-demand conference is designed to help you, to assist you as you make preparations for the upcoming school year. We will discuss tips and strategies to help your students with epilepsy succeed, not only in school, but in the years to follow. And above all, we want to say that we are here for you. For those of you that are new to our organization, this conference is just one of the many educational and engagement opportunities we have to offer to you. To learn more, please visit our website at epilepsymichigan.org or call our team in the office on our Here For You helpline at 1-800-377-6226. This conference is made possible by the Michigan Pediatric Epilepsy Project, which is managed by Children's Special Healthcare Services and the Michigan Department of Health and Human Services, with funding from the Health Resources and Services Administration. We offer many thanks of support, and we are grateful to partner with the Michigan Pediatric Epilepsy Project, both in this conference and in additional initiatives for children, youth, young adults, and families. For more information on the Michigan Pediatric Epilepsy Project, please contact the Epilepsy Foundation of Michigan. We have some fantastic sessions, speakers, and panelists lined up for you today. So now I will turn it over to Renee Roederer, our Senior Director of Programs and Community Care, to introduce our panelists for our first session. Welcome, Renee.
Hello, and welcome to our first session for our virtual on-demand back-to-school conference. My name is Renee Roederer, and I'm the Senior Director of Programs and Community Care at the Epilepsy Foundation of Michigan. I am so pleased that you have chosen to join us for this on-demand conference, and it's a privilege to welcome you here so that we can learn together and strengthen ourselves as advocates for students with epilepsy. Today's first session is entitled Understanding Medication and Cognitive Needs, Supporting Students with Epilepsy. And so I'm pleased to welcome two excellent speakers who will share with us about this topic, allowing us to explore the relationship between anti-seizure medications, their side effects, and students' cognitive and academic needs. So together we'll learn how different medications can impact learning, memory, concentration, as well as how to work with healthcare providers to optimize treatment plans for each student's unique needs. So with that, I would like to introduce you to Dr. Sarah Dixon, who is a pediatric neurologist with CS Mott Children's Hospital, and she will be sharing medical information with us about this topic. And I'd like to introduce you also to Russ, Derry, Pediatric Epilepsy Program Manager at CS Mott Children's Hospital, who happens to also be our former Director of Education at the Epilepsy Foundation of Michigan. So he'll be providing us with some practical strategies to address these needs. Thank you so much for joining us. So we will start with Dr. Dixon. Welcome to you. So I'll invite Dr. Dixon to share a screen. We will get started. Thank you.
All right. How does that look?
Very good.
Okay. Well, thank you so much for having me here today. I'm so excited to be joining you to talk about these really important issues. I think the timing of this conference is fantastic, and I'm so appreciative to the Epilepsy Foundation of Michigan for putting this on and bringing these issues, these discussions to the forefront as we head into the next school year, which is just right around the corner. So today I'll be talking about understanding seizure medications and the effects that they have on the body, on the mind, and on academic performance, and talking about some other cognitive needs that students with epilepsy have. We'll go ahead and get started. So I do not have any conflicts of interest to disclose, and I think it's important to note that I do not have any relevant financial relationships with any kind of drug or pharmaceutical companies related to this talk. So let's look at a roadmap of what we'll be discussing today. So we'll be looking into better understanding anti-seizure medications, how they work and why they're important, taking kind of a holistic approach to viewing side effects of medications and the different ways that they can affect our body and behavior, talking about what some of those risk factors are for having side effects of medications. And we're going to dive in and get a better understanding of the connection between epilepsy and learning disorders and epilepsy and ADHD. And I hope that you'll walk away from our discussion today with some ideas of how you can partner with your care team to address these issues early on if you're noticing that they're coming up. So anti-seizure medications. These are medications that are used to treat or prevent seizures from happening. So epilepsy, we know, is related to this abnormal electrical activity in the brain. And anti-seizure medications work on trying to regulate that abnormal electrical activity, either by decreasing how excitable those nerve cells are in communicating with each other, or trying to suppress, increasing the suppression between communication of nerve cells. And this picture on the right here, this very busy textbook diagram, shows all of the different locations where seizure medications can target that communication between nerve cells. And so we really have a lot of different targets out there that medications can act on. And a little bit of it is trial and error to figure out what is the best medication for any given patient. Now, with using any medications, including anti-seizure medications, sometimes we can run into side effects. I'd say this is particularly true when you're starting a medication or when you're in the process of going up on the dose of medication. And some patients tend to be more vulnerable to side effects. You know, when you're given a new prescription, a new medication, oftentimes there's a laundry list of potential side effects that can come along with it. And your care provider's job is to try and help inform you on what's the most common side effects that are typically seen. But we don't have a way of being able to predict exactly which patients are going to develop side effects. So again, there's a little bit of a component of trial and error that goes into finding the best treatment regimen for any given patient with epilepsy. And though seizure medications can come along with these challenges, I will note that if we're able to overall reduce the number of seizures that someone is having, in the long term, this is important for being able to improve your overall thinking ability, cognition, and development. So we'll talk about some common side effects that we can see with seizure medications. And I'm not going to pick on certain seizure medications in particular. So a lot of this will kind of be discussing what the most common side effects that we generally see. So we'll touch on what some of the more common physical manifestations of side effects that tend to come up. One of them is dizziness or lightheadedness, feeling kind of fainty, fatigue, feeling tired, sluggish, run down, changes in vision, whether it's seeing double or vision feeling blurry, difficulties with balance and coordination, headache, and stomach upset. Now, we can also have side effects that affect our mood and our behavior. So depression and anxiety, we know, can occur more commonly in kids with epilepsy. And so if those are there from the get-go, it's really important to note that and make sure that we're checking in on whether those symptoms are being exacerbated by the medications that we're using. Sometimes we see impulsivity, hyperactivity come out. There are some medications that are notorious for causing anger or rage outbursts. And I'll also say that you can have reaction to physical symptoms, right? That can affect your mood and behavior. So if you are feeling dizzy or lightheaded or off balance or tired all the time, that could certainly affect how you're feeling and what your behavior looks like, especially in younger children who may not have as eloquent of a vocabulary to be able to express the symptoms that they're experiencing. And I said I wouldn't pick on certain medications, but I think it is important to note that there are some treatments that can have actually a positive effect on behavior. And so when we're choosing a seizure medication for any given patient, we're really looking overall to see what's going on in the background so that we can tailor our choice of seizure medication for any given patient. There's really no one-size-fits-all approach. We want to look and see, is there a certain side effect that we really want to avoid? Or is there a component of a medication that could help with any underlying or comorbid co-occurring problems? And now let's dive into cognitive side effects. So this is related to thinking abilities, academic performance. And if you think about it, when we talk about what seizure medications are doing, how they're acting on nerve cells, it makes a lot of sense that seizure medications could have an effect on how the brain is functioning overall with your thinking ability. So really all seizure medications pose a risk for having cognitive side effects. And again, if there's any kind of cognitive impairment out the get-go or at baseline, this could be exacerbated by some seizure medications on top of that. Some of the more common symptoms that tend to pop up can be a decrease in your ability to process information and your reaction speed, reaction timing, troubles with focusing, concentrating on a task, memory, and typically this is short-term memory or what we call working memory, and executive functioning, which is the overall kind of quarterbacking of the brain, your ability to manage multiple things, to multitask, and fatigue. So fatigue is actually a physical symptom that we reviewed earlier on. But again, if you're experiencing this physical symptom of fatigue, feeling run down, like you just have not gotten enough rest for your brain and body, this can definitely affect your thinking abilities and processing speed. So what are the highest risk situations and times when we could be seeing side effects from medication? So anytime you're starting a new medication, this can be a high risk time for developing side effects. And it takes a little bit of time for your body to adjust to something new, and that could be expected. So I usually say giving it a week or two to kind of see how things are settling out. But certainly, if you're noticing really dramatic or really debilitating side effects, it makes sense to, it's definitely an option to kind of jump ship and switch to something different. And that period of increasing the dose of medication can be a time where side effects can be more pronounced. And then polytherapy, which means taking multiple medications at the same time, can have this kind of stacking effect with side effects. So this could be taking multiple anti-seizure medications together. We can certainly see that happen, but also there's a possibility of this coming up when you're taking a seizure medication and any other type of medication. And so we really try to reduce polytherapy as much as possible when we can. So we'll switch gears here a little bit and talk about learning disorders in kids with epilepsy. So a learning disorder is a condition that interferes with your school performance or your day-to-day activities that require reading, math, or writing skills. And this is in someone who has a normal IQ, but is having trouble with reading, math, writing. So the right here, you see this little pie chart that shows all of our different sort of medical terminology that we use for learning disorders and practically what that means. So some kids, we think about reading, writing, math, but there's also specific trouble with spelling skills, specific trouble with fine motor skills, and then processing of visual information and hearing the difference between sounds, processing auditory information. And it's estimated that a quarter of children with epilepsy have learning disorder. So this is very important to have on our radar as kids are going through school and looking to see, are there certain areas where they seem to be having trouble so that we're able to better support them. And the risk factors for developing a learning disorder are what we call multifactorial, meaning there can be a number of different influences that play a role in the risk of having a learning disorder. One of them can be a genetic predisposition. So if there are other members in the family who also experience learning difficulties, that can increase the risk of a child experiencing a learning disorder. What the psychosocial environment looks like. So this is social determinants of health. This is adverse childhood experiences or stressors, trauma, and also what the support system looks like in the school environment and the home environment. Like we mentioned before, it could be medication related, but it's also important to consider if this can be related to epilepsy itself. There are some epilepsy syndromes that are associated with learning disorders. So sometimes we get in a situation where we're saying, well, is it the chicken or the egg, right? Is it a symptom of medication side effects, or is this a symptom of the epilepsy itself? There are some factors that can be predictive of developing a learning disorder, meaning there are some features that could increase your risk for having learning difficulties. And those are having an onset of seizures at an earlier age, so before age 2 years old, having a higher number of seizures overall, and having multiple types of seizures. So essentially what this is saying is the longer that you've had epilepsy, if it started at a very young age, and the higher the burden of seizures that you've had overall over that time, that could increase the risk of having a learning disorder down the line. Now, I'll briefly touch on epilepsy and ADHD, the connection between the two. And I will say that this could probably be an entire topic for a talk in and of itself, but we'll try to hit the highlights. So ADD, ADHD, this can come hand in hand with children and adults who have epilepsy. It's estimated that the risk of ADD and ADHD is 2 to 5 times greater in those with epilepsy than with compared to the general population. And there are multiple different flavors of ADD, ADHD. So you can have a hyperactive and impulsive subtype. And these are kids that tend to be diagnosed pretty readily, pretty early on, because their symptoms are very physically apparent. So these could be kids in the classroom who are up and about, moving a lot, talking a lot, maybe have some impulsivity. So doing things or saying things, maybe without thinking them through all the way. Trouble taking turns and waiting, interrupting others, blurting out answers. Again, these are things that are often really visibly apparent and can lead to an earlier and can help with leading to an earlier diagnosis and intervention. There's also an inattentive subtype of ADD. And I think of this as the student in the classroom who's kind of the quiet daydreamer. So this is a student who might make some silly mistakes in their work that you might not otherwise expect them to make, could have trouble with listening and following directions, especially if they are multiple step directions. This could be a student who they complete their work, but they simply forget to turn it in, might have trouble keeping track of their belongings, and completing tasks that require really sustained mental effort. And this is something I want to dive into a little bit more because, someone may look at a child and say, oh, there's no way Jimmy could have ADD. He's able to focus on video games for hours at a time. His attention is really good. But when it comes to doing something like math homework, or maybe something that a child doesn't have a particular interest, really heavy interest in, just at baseline, it can require a lot more effort to do a task like that. And so sometimes this symptom of inattentive ADD is that it can be perceived as having a lack of motivation, when really that's a mischaracterization of a symptom of inattentive ADD. And I will also note that girls who have inattentive ADD tend to fly under the radar and are often diagnosed later and have intervention started later than, compared to kids with that hyperactive impulsive subtype. Again, because it's less of a, physically apparent or potentially disruptive subtype of ADD. And then you can have a combined subtype that has features of both of these types of ADHD. Some people are at an increased risk beyond just having epilepsy of developing ADD or ADHD. And this can be if there's also developmental delay or intellectual disability in the background, along with other family members who have epilepsy or ADHD. So all of this to say that it's really important to be partnering with your care team to have frequent discussions and check-ins about how things are going with seizure medications, whether we're seeing side effects, what kind of impact those side effects are having on our day-to-day function, and specifically looking at how things are going at school, both with academic performance and mood and behavior. It's important to know that most side effects are reversible. So it's important to bring them up so that we can try to address them together and troubleshoot the situation. Some medications can cause abnormalities in labs that could affect physical symptoms that you're experiencing. So checking in on some of those labs can be helpful. For some medications, we can monitor drug levels in the body to see how high they are. And so checking labs can sometimes be a good first step in better understanding how medications can be playing a role with side effects that are happening. Now, if you are experiencing side effects, we have a lot of ways to troubleshoot the situation. So if we're just starting a medication or going up on the dose, we can really slow down how quickly we're increasing it so that your body is able to have a more gradual adjustment to a new medication or a higher dose. We can try to lower the dose of the medication and see if that is sufficient to improve the side effects that we're seeing. Or we can switch to a different seizure medication altogether. We have so many options out there for seizure medications, which is fortunate. Way back in the day, there were only a few, but in today's day and age, we have so many different treatment options for epilepsy that it really does not make any sense to continue with a medication that is causing side effects that are interfering with your functioning or your quality of life. And then we also want to reduce polytherapy as much as we can. So again, polytherapy is taking multiple medications at a time. So anytime you're starting a new medication, it's worth a discussion about whether there are other medications that you can come off of, so that we're able to reduce the overall number of medications that you're taking. And I encourage you to discuss concerns for learning difficulties early on. So as soon as this starts to become, even a notion of a concern, it's worth bringing it up and having a conversation, because what we often do is try to connect families with sort of learning evaluations and then lead to more educational support. And that process of getting all of those ducks in a row sometimes takes longer than we would like it to. And so it's really important that at the earliest notion that something like a learning disorder or ADHD could be playing a role, you really want to have that conversation with your care team early on so that they're able to connect you with the evaluations and resources that can best support your students. And so with that, I am so excited to hand things over to Russ, who is the expert in connecting families with resources, particularly students with epilepsy in the educational environment. So thank you for having me, and I'm happy to take any questions.
Thank you so much. And that was absolutely excellent. Just really both an excellent overview and also very empowering, right? We can use our voices to share what we're experiencing and what our children are experiencing. One question I might have is, like, for younger children or maybe older children who are not verbal or less verbal, what are some signs that parents and family caregivers might look for in terms of side effects, to kind of try to manage some of that?
It's a great question. I think neurologists are experts in diseases and disorders of the nervous system, like epilepsy, but I'm often telling families that they are the experts in their child. And
Right.
so if you're noticing some type of behavior change that seems really off or different than what is typical for your child, it's really important to bring that up, particularly in kids who are nonverbal, because the way that they communicate pain, sometimes they can have a specific way of communicating. And so I'll often ask families, what does your child typically look like when they're in pain? How do you know they're in pain? How do you know something is off in their body? And a lot of times they'll say, oh, I notice X, Y, or Z specific thing, because they are so in tune and they are that expert in their child. When it comes to things like nausea, sometimes we see kids will just refuse medication. So there can be some component of medication refusal or difficulty with giving medications that can also give us a sign that the child is trying to tell us that they don't like either the taste of the medication or how that medication is making them feel overall. And behavior is a really important marker. When we're seeing behavioral disruption or disturbance, it can be a number of different things. That it's really important that we take a holistic approach to trying to assess, looking at sleep, looking at medications, looking at environmental triggers, changes in the family dynamics or social changes and stressors. It's really important that we're able to take a holistic view to behavior, especially in kids who are limited in their verbal abilities.
Yeah, that's so helpful. Thank you. So really looking for what's out of the norm. And I love that sense of, yes, parents are the experts on their kids, and that's absolutely true. Likewise, when a student is getting older and maybe taking a little more responsibility for their own care, how can parents empower their communication with physicians on these kinds of topics when it comes to side effects, things like that?
Wonderful question. So as teenagers are growing and getting into the role of, slowly becoming the person who's in charge of their medical care, I think it's really important that parents, like you said, kind of empower their kids to be their own voice. And so the kids who I see have sort of the smoothest transition from, seeing a pediatric neurologist through and making that change to an adult provider are the ones who has had the practice in it, who you've been starting that conversation, at it kind of around 60, I think 15, 16 is a good age to be starting these conversations so that they kind of know what to expect down the line and know that there's that expectation and that, kind of standard that they will be the person who is in charge of communicating their needs and communicating the symptoms that they're having and understanding their epilepsy overall. So I think as much as parents are able to, and providers are able to open this conversation about that process of gradually taking more and more responsibility over your condition and treatment and reporting of side effects, the smoother transitions kids have going into adulthood.
Oh, that's so good. And for those who are watching, we're going to have a whole session on transition in just a little bit, medical transition in healthcare and also in education. So thank you so much, Dr. Dixon. This has been tremendous. You have helped so many people today, and this will continue to be viewed and shared and provide that for many more families. So thank you. And now I'd like to invite Russ Derry to the screen, who's going to share our second portion of this session. Thank you.
Thank you. Let me go ahead and share my screen. Okay. Well, thank you, Renee, again for inviting me, and thank you, Dr. Dixon, for a really informative first half of the presentation. So I'm going to kind of pick up where Dr. Dixon left off. She had mentioned that there are a number of other factors in addition to anti-seizure medication that can influence cognitive function. So I'm going to talk about some of those factors, what that impact can be on cognitive function and school performance, and then some different strategies, tools, and resources and professionals who can help. So one of the first things that I think is really important, if you suspect that your child is having any kind of cognitive or academic difficulties, is evaluation. And there's two kinds of evaluation that are I think are both helpful. One is the school-based evaluation that the school can offer, and that is usually going to you're going to work with a multidisciplinary evaluation team at the school, and they're going to gather data and input from teachers, from other school staff. They may look at past testing results, past grades, things like that. And then there will also be a psychoeducational evaluation. And this is a relatively brief 2 to 4 hour evaluation that is really focusing mostly on your academic performance related to peers. The other type of evaluation that I think is really important to seek out, because it goes much more in depth and can really help inform what strategies might be helpful in the academic setting and in the home setting, is a neuropsychological evaluation. And this is provided by a neuropsychologist, and this takes a lot longer. It's usually 6 to 8 hours. It's about twice as long as a psychoeducational evaluation. And it is really directly tied to the child's neurological condition. So everything you're learning about their cognitive function is how that cognitive function is affected in the context of their neurological disorder and its treatment. In addition to being helpful in the school, this will also be, the information you gain from this will be very helpful outside of the school, just in terms of daily functioning. So there are a few different places you can get a neuropsychological evaluation. Comprehensive epilepsy programs throughout the state and throughout the country offer neuropsychological evaluation. Often this is a large part of pediatric neuropsychologists who are affiliated with comprehensive epilepsy programs. A large part of their practice is related to epilepsy surgery. So it's for pre-surgical evaluation and then follow-up after surgery. But many of them are also able to do neuropsychological evaluations just for a general assessment of cognitive function that can be used for school and home and that sort of thing. There are also community-based or private practice pediatric neuropsychologists as well, who may have a much larger portion of their practices, just these general neuropsychological evaluations outside of the context of surgery. There are not that many pediatric neuropsychologists out there, so there are often fairly long wait times to be able to see them. In most cases, it is covered by insurance, although that can vary depending on your individual coverage. What you come out with after a neuropsychological evaluation is a written report that really goes over all of the different cognitive domains and strengths and weaknesses and how it relates to norms and peers of the similar age. And then there will also be a section that really talks about some strategies. How do you deal with these cognitive difficulties that have been identified? That does tend to be a smaller part of the evaluation. One of the really important things is to share this neuropsychological evaluation with your IEP team at the school or others that you're working with at the school, so that they can take the information from the evaluation and kind of translate that into day-to-day strategies and supports in the school setting. Okay. Dr. Dixon had mentioned many of the different cognitive functions that can be commonly affected in children with epilepsy, and I'm just going to kind of review some of these and talk about some of the common tools and strategies that might be used to help. So memory is one of the most common things that's affected, and again, particularly short-term memory or working memory. There are, when you look back, 20 years ago, the absence of smartphones, it was a lot more challenging to deal with some of these memory problems. But now with smartphones, there are so many apps and so many tools on smartphones that can help with reminders, help with taking notes and other things to really help compensate for memory difficulties. They're making lists, to-do lists, those types of things, various prompts that you can set up to help you remember things. And again, these are all things that you can work with, or talk with a neuropsychologist, work with other professionals to help develop and refine these strategies. Attention, and we mentioned ADHD. So minimizing distractions is a very common thing that can be used in the school setting. And often with like ADHD, you may not need, if your primary cognitive difficulty is just ADHD, and in many cases, the types of accommodations you need may not actually warrant having an IEP. Sometimes just a 504 plan would be sufficient to be able to put some of those accommodations in place. And that's something that I think there's another session at the Back to School conference that we'll be talking more specifically about IEPs and 504 plans. So I'm sure those presenters will be talking more about that. But also ADHD meds. There are medications for ADHD, stimulant medications, for example, that actually can be safely used in children with epilepsy. And I think that's, a common concern is, oh, if I'm taking a stimulant medication, is that going to make seizures worse? But they are not actually contraindicated and can be safely used in children with epilepsy. So they can make a significant difference, and that's something definitely to discuss with your healthcare team. Also, sometimes just having extra time on tests can be helpful. Executive function, these are, again, these higher level functions, things like decision making and multitasking and initiating tasks and breaking down tasks and that type of thing. So a number of different strategies that can help with that, having written instructions, again, because multi-step things can be a little more challenging if you have an executive function disorder. Again, if there's a large task or a large project that you need to complete, breaking that down into distinct activities and distinct tasks or goals or objectives that you need to achieve can be helpful. The more structure or organization you can put in place, the more successful generally you're going to be with executive function, and that's both in the school setting and in the home setting. There's also, and we'll mention this a little bit later, there are professionals called executive function coaches that specifically work with students and children to develop these kind of organizational skills and these structures and these habits and routines that can help to again provide that structure that makes that helps compensate for these executive function challenges. Processing speed is another common thing that can be slowed either by anti-seizure medication or other factors, and sometimes just simple accommodations like having extra time on tests. Just being patient when you're talking with someone, because it may take a little bit longer to process the information, and often sometimes medication adjustments. Again, if it's thought that some of those processing speed difficulties are related to side effects. Language can be affected. There are certain types of epilepsy syndromes that actually involve a language regression, for example. So working with a speech language pathologist, there are augmented alternative communication devices that can be really helpful for those who are nonverbal or have limited verbal capabilities. IQ is another domain that can, there are a significant percentage of kids with epilepsy who have some sort of global developmental delay or intellectual disability. And in most cases, modifications to the educational program may be warranted in those cases. And things like extended school, either extended school year, where you have additional classes and work over the summer, or actually extending the amount of time that you're in school so that you can actually continue taking classes and getting support up through age 26. And then there also may be specific functions related to the seizure focus or the area of the brain that's being affected by the epilepsy. And really, again, the types of strategies that you would use in those cases are really dependent on the area of the brain that is affected. Obviously, anti-seizure medications and side effects from them can contribute significantly to cognitive difficulties, but there are a number of other factors as well. And some of these are a little less modifiable. I wouldn't say that they're crystallized or unchangeable, because there are some things, some advances where we might actually be able to address factors that 20 years ago we couldn't. So things like your underlying brain condition or injury that is causing the epilepsy and maybe causing other difficulties as well. Often we're not able to really address that medically. But again, there are some circumstances in which epilepsy surgery may be able to actually improve cognitive function if it's removing an area of the brain or modulating an area of the brain that is disrupting a normal cognitive function, or that is causing seizures, which are then disrupting cognitive function. Also, some types of epilepsy may create progressive changes in the brain over time, and that can be something that is challenging or difficult to reverse. And then also genetic factors can contribute to cognitive challenges as well. And while we may not be able to change things that are inherited, there are things called de novo mutations, which are mutations that happen that are not inherited, and that we're now with advances in genetic testing and gene-based therapies, we can actually, there are some instances in which we can create develop these precision therapies that can actually address the underlying genetic causes of epilepsies and also some of the cognitive challenges that may go along with those genetic variants. So those are the ones that are kind of harder to address, but there are a number that are much more open to modification. So treatment side effects, we already talked about that. Obviously, the adjustments you can make there, but also the effects of seizures themselves. So it is important to realize that while medications are maybe causing side effects, they are also, if they're effective in reducing seizures, that is likely to improve cognitive function itself, because the effects of seizures themselves, both before the seizure, during the seizure, and after the seizure, as you can imagine, after a seizure, that post-ictal period, for example, you're not functioning at 100%, and that can sometimes drag on for hours or days or even up to a week after a seizure, where you're just not at 100% functioning really. There's also things called interictal epileptiform discharges, which is abnormal electrical activity in the brain that is characteristic of epilepsy, that occurs between seizures. And when these occur, there is some evidence to suggest that can at least temporarily disrupt cognitive function. And the way you address that is, again, by improving seizure control. So if medication is working to improve seizures, it's likely also helping with those interictal epileptiform discharges. There are also things called epileptic encephalopathies, also referred to as DEE or DEE. There's one example of that is something that used to be called ESES, or it's now called DEE-SWAS. This is basically abnormal electrical activity that occurs during a certain stage of sleep, and that kind of disrupts that restorative process of sleep, the things that are supposed to be happening during sleep to improve memory function and aid in the continued brain development, are being disrupted by this abnormal electrical activity. So with this, you can see delays in development. You can also see cognitive difficulties. So there are specific therapies and treatments that are designed to address that activity, that abnormal activity that's going on in the background during sleep. And that's separate from just standard anti-seizure medications. And that's something that, again, if you don't have an EEG or long-term EEG monitoring to identify that, you may not know that that's even going on. Sleep difficulties can be a huge contributor, and I think often underestimated how much that contributes to cognitive difficulties, in addition to mood difficulties and also making seizures worse potentially. So anything you can do to improve sleep is likely to improve cognitive function. Obviously, with epilepsy, there's a lot of stress related to living with an unpredictable and disruptive condition. There's the stigma and social isolation that may go along with it as well. So if you're constantly worried that you might have another seizure, if you're experiencing any kind of bullying, or those things are only going to interfere with cognitive function. So again, anything you can do to address any bullying that may be occurring, or help the child develop and practice some relaxation exercises, or getting counseling if stress or anxiety is becoming a problem. And the last item here is depression and anxiety. So like I said, that's much more common in children with epilepsy than the general population. So getting that addressed by seeing a mental health professional, or also talking with your healthcare team about medications if appropriate for that as well. So there are a number of professionals both inside and outside of the school that can help. I'm not going to talk too much about school personnel because, again, there's going to be another session on that, but your IEP or 504 team includes a whole host of of educators and other school professionals that work together to identify challenges in the school. They can look at that neuropsychological evaluation and come up with strategies and supports on a day-to-day basis that can help that child thrive in school. So making sure you get to know all of those members of that team, find out what they can offer, what they can contribute to your child's school experience, and don't hesitate to reach out to them. Additionally, of course, your epilepsy and your healthcare team is really important to communicate with them about any difficulties your child is having. As your child gets older, encourage them to also bring up any concerns or questions that they have. Neuropsychologists, we mentioned they primarily work in terms of the evaluation side, but they can also be a resource in terms of developing strategies and interventions. Psychotherapists, in addition to dealing with things like depression and anxiety, there are many psychotherapists and counselors who specialize in ADHD or intellectual disability or learning disabilities. And there are search tools like on Psychology Today, which is a website where you can actually look at specific skills or areas of expertise or interest that psychotherapists have, and you can find those who really focus on those cognitive difficulties and can help a child develop strategies for dealing with those. Occupational therapists, I think a lot of people think of occupational therapy really as more of a physical thing. And of course, occupational therapists can focus very much on learning physical skills and practicing physical skills, but they can also work a lot in terms of cognitive function. And that's an area of training that they receive and are able to share that I think a lot of people don't know about. And that's the same is true with speech language pathologists. In addition to dealing with speech and language difficulties, they also are experts in cognitive function and can provide a lot of both ways to improve cognitive function and to develop these compensatory strategies for any kind of cognitive difficulties. There are case managers both through the school in many cases, and then also through CMH or community mental health that can help identify resources and make sure that it help coordinate and navigate all of those different resources. I mentioned earlier executive function coaches. They're basically, I think you have to just go and Google executive function coaches to find them. I don't know if there's a particular organization that helps you find them, but there are many of them out there. Just look at kind of what their training and their expertise is, and they can again work with your child one-on-one over time, because it does take time to develop these strategies and routines and habits that help compensate for those difficulties. Of course, tutors can be offered through the school and outside of the school. And also, as your child gets older, and particularly if they're staying in school beyond age 18 and up to age 26, vocational rehab counselors are through Michigan Rehabilitation Services, are often available through the school setting, and they work with the schools to help develop skills that can translate to employment opportunities as the child gets older. Another thing I just wanted to mention is that in addition to many of these services being available outside of the school setting, there is you can receive some of these services in the school setting through this school services program, which is a federally funded and state-funded program that provides partial reimbursement for these healthcare, what you would generally consider as healthcare services, but that are provided during the school day. The Direct Services Claiming Program provides specific medical services that are or funding for services that are in the IEP, and the Caring for Students program kind of broadens that to the general education students who may have a 504 plan or other plan of care. So really anyone who needs this can access these, and this can cover things like psychotherapy, occupational therapy, speech language therapy, case management, and assistive technology services, all in the school setting. That way the child doesn't necessarily have to leave school to obtain these types of supports and services that may be equally valuable to the academic instruction that they're receiving in the school. And just some closing thoughts here. So to kind of wrap up, in addition to the medication side effects, there are very many other factors that contribute to cognitive difficulties. And fortunately, many of those factors are modifiable or things that you can address. And really, everything that you can do to address those makes a difference. So minor improvements really add up to this, and it can have this cumulative impact on school performance. So when you're talking with your healthcare team, always kind of keep cognitive function as a priority. It is, just as important as talking about seizures. You need to also consider this cognitive function, and again, the many different factors that contribute to that. And then if cognitive difficulties do persist, despite attempts to address them both medically and in other ways, behaviorally, for example, there are a variety of tools and strategies and professionals, both inside and out of the school, that can support you and help you, again, compensate for some of those difficulties. So that is all I have. So thank you so much. And I'm happy to answer
thank
any
you
questions.
so much. Yeah, I am so grateful for that whole presentation because it was very thorough, and I think also just gives a lot of hope and help because, as you said, there are many professionals who can really play a role in providing information and also assistance. So one question I had is just about comprehensive epilepsy centers, if that language might be new for anyone who's watching. Some of these resources and professionals can be accessed through the school, certainly through referrals of whatever doctor you may be seeing or whoever you may be seeing. But what is a comprehensive epilepsy center, and how might that help unlock some of these resources?
Right. Yeah. So a comprehensive epilepsy center, there are different levels, but most of the comprehensive epilepsy centers in Michigan are level 4 comprehensive epilepsy centers, which is the highest level. And they provide access to the full range of diagnostic and treatment options for epilepsy. And they are staffed by epileptologists, They also have EEG techs and neurosurgeons, and most have ketogenic dietitians as well to help with the ketogenic diet if that's a therapy that's chosen. So they really offer this full, I mean, like the name suggests, comprehensive epilepsy care, and all in one setting. And often they're part of large health systems too, so that if there are other difficulties outside of the epilepsy or connected to the epilepsy, associated conditions, it's very easy to coordinate care between different specialists. But again, we always recommend that if you have what's called drug-resistant or intractable or refractory epilepsy, which is when seizures are continuing despite two appropriate medication trials that are that at that point the likelihood of medications alone controlling seizures is lower. So that's when we really recommend going to a comprehensive epilepsy center to be able to access other treatment options that are available.
That is excellent. And at the Epilepsy Foundation of Michigan, we have connections to all of these centers and lists of the epileptologists who work there. And so these other kinds of professionals, it's not to say you can't access them, wherever you live and whatever kind of care you're receiving, but these are also places where sometimes you can find it all in one place, just as you said. So I think that's really valuable. For parents or family caregivers who may be curious about certain kinds of diagnostic testing, for instance, you had mentioned with DEE-SWAS, formerly known as ESES, like a 72-hour EEG may be very helpful. And without that, how would you know what's going on? So like if family caregivers are thinking about that, or neuropsychological exams, how can they use their voice, in the best way to sort of request that with their physicians and their care team?
Yeah, I mean, generally, the care team is probably going to identify that and the need for that and suggest that, but it's possible that it's not brought up, and that's again where the parents are their best advocates, and they know their child, they're the experts. So if you are concerned that your child is struggling and you're not sure why, and you want to get to the bottom of things, there are definitely, push for that app. Talk to your neurologist or epileptologist and say what else can we be doing to address this? Because again, all neurologists and epileptologists have a limited amount of time in those visits to address all the things that need to be addressed. The seizure control, the treatment side effects, all of that. So that it's sometimes possible that cognitive function kind of takes a back seat. So I think it's so important for parents to keep pushing that and keep that as a priority. And
to come in really with a list of things you want to discuss. And that your eyes, your ears, your observations about your child are so important. So I just want to thank you both so much, Dr. Dixon and Russ. This has been remarkably helpful with your expertise and experience. And now in our next session, we're going to talk even more about strategies to apply this knowledge into things like IEP planning and 504 accommodations and other kinds of strategies, because we want to make sure that our students are set up well for success in the classroom. So thank you for joining us.
Thanks so much for having us.
Thank you very much.
Welcome to our second session of our Back to School conference. This session is entitled Navigating the Educational System, Overcoming Challenges, and Achieving Success. Again, my name is Renee Roederer, and I'm the Senior Director of Programs and Community Care for the Epilepsy Foundation of Michigan. And I'm deeply grateful to welcome three speakers who will share strategies and stories to help us navigate the educational system effectively, from understanding IEPs and 504 plans to fostering positive communication with educators and administrators. This session will equip us as parents and caregivers with tools and knowledge needed to advocate for every child's academic and social success. So with gratitude for their experiences and perspectives, I'd like to introduce our speakers. So please welcome Kelly Kiss, who is a retired special education teacher, an assistant professor of education at Saginaw Valley State University, and a state complaint investigator at the Michigan Department of Education. She is also, gratefully, a member of the board of directors at the Epilepsy Foundation of Michigan and has several personal connections to epilepsy through her family. And I would also like to welcome Jasmeen, Khilji, and George Blower, who are parents of Paloma, a young adult living with epilepsy who recently graduated high school and will be attending the University of Michigan in the fall. So I'm grateful that they will share a parental perspective on this topic today. Thank you for being with us. So let's begin with Kelly. Kelly, I'm wondering if you could introduce yourself and share a bit about your work and explain why this topic is particularly important to you.
Thank you, Renee. I would love to do that. So I was a special education teacher for 26 years. It was just I love working with young children with disabilities. Also, part of my career was I was a 504 coordinator for the entire district at our large school here in Saginaw. And so I really enjoyed that position because I could help. I was still doing some special ed things, but I could also help all students with disabilities and with 504 plans, and especially bring my expertise of epilepsy to that table. And I enjoyed it, especially when parents would come in and I could see them being very nervous about sending their child to school with epilepsy. And I was like asking all the right questions and they'd be like, how do you know all this? So then I'd be like, well, guess what? I know some things. So that was a big part of why I loved what I do. I could help all children, but especially children with epilepsy. I had a cousin, Jenna Rose. She was 19 when she died from epilepsy. So a year later, we started doing the summer strolls for epilepsy to get involved and to do some good for the epilepsy community. So after doing that for many, many years, my Uncle Jeff was a longtime member on the Epilepsy Foundation board and kind of got me to join. And I was very lucky to become a member of the Epilepsy Foundation board of directors. I really enjoy that. And then my daughter, 5 years ago, started dating a young man and he has epilepsy. So I am helping him navigate the college classrooms and how I can help him so he knows all his rights and what he should be doing to make sure that he's safe in college. Because when he was a freshman at a smaller university, he had a seizure, the first one he'd had in 8 years during class. And the professor and nobody in there knew what to do. Luckily, when they made the all call that said there was someone having a seizure, his roommates were next door and he had shared with them and they came over and made sure he was safe. But that teacher told him afterwards, like how she had no idea what to do. So that is part of my goal with my position here at the Epilepsy Foundation. And then doing these conferences is to make sure everyone in the world knows what to do when someone has a seizure so that our epilepsy community feels safe no matter where they go, especially in schools. So
yeah, we are profoundly grateful for every piece of that you just named. And I think all of those intersections, personally, professionally, and just who you are as a person, I think really shines through and is so helpful today as we prepare many students for school this year. So thank you. Exactly. To begin, I'm just aware that some parents and family caregivers may be completely new to all of this. And for those of us who have been doing this for a while, there's always more to learn. So I'm wondering if you can start by explaining the basics of IEPs, 504 plans, seizure action plans, the kinds of things you want to have potentially on record for a student with epilepsy, and certainly the seizure action plan, but maybe some of these other pieces. So can you share a little bit about what these are and maybe what some of their differences are?
Yes.
Thank you.
I love doing this. So an IEP is an individualized education program for students who qualify for special education services. So not all students with epilepsy will qualify for an IEP, okay? They have to be showing that it's adversely affecting their educational performance. So in my experience, it's been students that are having more consistent seizures, that it's really affecting their ability to learn and their cognitive development. So those students typically qualify more for an IEP. They would qualify either with a specific learning disability sometimes, or there is a category called otherwise health impaired. So remember, otherwise health impaired being a big one. When you go to your district, otherwise health impairment is one you want to talk to them about. Later on, I will speak about how to get an IEP. But an IEP can be a resource room help for your student. It can be speech and language services. It can be a classroom that they have to go to outside of the class, your regular ed classroom. An IEP is individualized for every student. It has goals and it is a legal document. So the schools they have to do everything in that IEP. It is a legal document. So it really guards our students with disabilities and makes sure that they are getting what they need at school. It's a little bit more in depth. I'll go over the evaluation piece later, but it is a special education piece of our schools. It is reviewed minimally once a year, but parents have the right to ask for an IEP at any time. The biggest thing I need to get across is, as a parent, you have all the rights. That is your child. Do not ever feel bad for wanting to get your child's team together to talk about an IEP. Now, a 504 plan is different. A 504 plan is not special ed. All a 504 plan does is gives your child accommodations in the classroom. So having an epilepsy diagnosis from a doctor, you would share that with your school, obviously. They would just give accommodations, just either if they're having seizures all the time, or even if they're not. Like when my daughter's boyfriend was in high school, he had one. He didn't have to use it, but it was always in place. It also makes sure our students aren't discriminated against. Oh, well, you know, that sometimes teachers, just by lack of knowledge, they're like, well, they can't go on field trips, they have epilepsy. That's discrimination. That is not allowed. We do not let that happen. 504 plan protects you and your family and your child against any sort of discrimination. It is done through the Office of Civil Rights. Your school will do it for you, but the Office of Civil Rights is the one that makes sure that 504 plans are being enforced and being used. So they don't get pull-out programs. They don't get special help. It's just like sitting closer to the teacher, extra time. I'll go through more accommodations when we get to that part. 504 plans don't have as many rules to them. They don't have to be reviewed every year. But once again, as a parent, I would recommend at the beginning of every single school year that you get that team together and make sure that they know what's going on with your child medically and if there's been any changes. A 504 plan will have your child's seizure action plan as part of the 504 plan. And that's what you really want. Maybe your child doesn't need any accommodations right now, but you can still have a 504 plan and have that seizure action plan in it just to protect your child. And every training I've been to with all the educational lawyers, they recommend schools do that. So when schools don't do that, I'm always shocked because they should have them in a 504 plan for their protection and the child. So, and that seizure action plan is we need to make sure everybody knows if your child has a seizure, what are the steps? And so that is so important. And then also at those 504 meetings, I was always like, the principals will be like, great, we have a plan. I'm like, okay, who's sharing it with the staff? I always made sure every person that interacted with that child, whether it be the bus driver, recess, lunch, art teacher, music teacher, everybody knows what to do in case of a seizure. So I always ask the schools or the principals, okay, who's in charge of training the entire staff? We are working on that bill, the Seizure Safe Act, for that all teachers and educators, when they start school, they have to have that as part of their training. So I'm really hoping that's going to be part of it, but every child's seizure action plan might look a little different. Some students have rescue meds and some don't. So just knowing all those things, and once I feel like educators know what to do, it takes some of that fear away. And getting them to understand, like, this could happen. They're going to be okay. This is how you're going to keep them safe. And as we know, 1 in 26 in your lifetime, you're probably going to see other people in other settings with epilepsy. So that training is great for everybody, because we're all, everybody's going to see a seizure at some point in their life, I believe. And then some schools may only want to do a seizure action plan. So they might not want to do a 504, that your child doesn't need an IEP. So once again, that would just have when to call 911, who to call, what to do. I like to have the classroom cleared just for that child's dignity, that no one needs to watch that. And only have the people, usually every school has an emergency response team, that those people are in there. They know not to call an ambulance unless it's over 5 minutes or whatever their seizure plan is. So some schools might just do that seizure plan. Once again, if that's all your child is getting, and you aren't going to push for the 504 plan, you make sure at the beginning of every year you've met with administration and said, does everybody know this? And if the child, some kids are a little bit more private about it, other kids are more than willing to talk about it. And so I would recommend, let's let everybody know. I mean, when we put children with autism into general ed classrooms, someone goes in and teaches the classroom about autism, and those kids become amazing mentors. Same thing with epilepsy. Once you get everybody on board, they're not going to be so worried. It's not fun to see a seizure, but you know what to do. When you know what to do, it kind of helps your nerves a little bit. So even letting other children in the classroom know, but that's all based on that student and how comfortable they are. When I told the story about my daughter's boyfriend in college, luckily he was on the baseball team, and they all had to share what's been your biggest mountain to climb. So he obviously shared his epilepsy. So luckily he did that, and he knew he needed to do that. But at that point he was 8 years seizure free. So when he was sharing it, he kind of wasn't thinking that was going to happen right away. But I told him, you need to, he's older now, he's 22. I'm like, you need to be able to tell that to people, mostly for the workforce and so on and so forth. So I talk to him all the time. Poor kid has 2 moms telling him what to do all the time. Okay, so I think I answered all those. We're gonna talk more in a little bit more clear about IEPs and 504s.
That is so great. I just want to say everything you've said this morning already feels so empowering, right? Just for parents and family caregivers to know you have rights. Your children have rights. You are able, and we recommend, starting those conversations and being advocates, and to know you're not alone on this journey, right? We are here for you at the Epilepsy Foundation of Michigan. And also, if you are needing something really practical, like a template for a seizure action plan, which is typically filled out between you and the physician, and is given to the school and filed, and shared, as Kelly has said. We're here to help with that process. If you need some help in your school, doing some training with educators and school professionals, we are able to do that. We have opportunities for people to do that on demand. We have opportunities for us to come in person or to do those things virtually. So you don't have to do this alone, and you are super empowered in this process. Yeah, you have rights. It's lovely to think about and flex, right?
100%.
And I also love that you are really empowering school professionals too. And that's another thing that we believe in, because we want educators to be able to do their best work and to not be so completely caught off guard. And witnessing a seizure can be very difficult, right? It impacts our nervous system as well when we see those things happen. So first and foremost, we want those educators and school professionals to be able to respond with appropriate and helpful seizure first aid. But we also want them to feel empowered and not have, a difficult experience. So we're on everybody's team here, which is great. Okay, so let's dig in a little bit deeper on these IEPs and 504 plans. What are some common challenges that families face when planning and implementing IEPs and 504 plans for their students with epilepsy? What sort of themes do you see emerge most?
Well, first of all, like I said before, sometimes schools are reluctant to do testing for special education or to do an evaluation for a 504 plan. So I'm going to tell you a million times in this presentation, you email your principal, or the principal for a 504 plan, and the principal and the special ed director or supervisor of your district, and you put it in an email in writing when you're requesting an evaluation for a 504 plan and an IEP. Once it is in writing, they have to do it, okay? So I just want to make sure you know that. There is a wonderful website, and I know Epilepsy Foundation shares it with parents, the Michigan Alliance for Families. This website has everything you need to know for your meetings, what you need to do, how to prepare. It's a fabulous website, Michigan Alliance for Families. So make sure you educate yourself as you're going through this process. We're going to give you some glimpses into it, but that website is so great for families and it really empowers you. When you ask for that 504 evaluation, if you're new to the district and it's like, say it's August and you're getting ready for the new school year, you need to say that your child has epilepsy and that you need to, regardless of if they're going to wait a month to, meet your child and decide if they need accommodations, you need a seizure action plan in place before school starts, just like I said. When you have 504 plans, especially, IEPs are more legal. So you have special education teachers taking data and making sure everything is being done correctly in terms of accommodations. A 504 plan, sometimes districts kind of get loosey-goosey about it and you don't always know what's being done. So when you're in your 504 meeting, you need to ask, hey, so who's going to make sure my child is getting these accommodations? Typically, it's like a school counselor or a social worker, but you need to ask that person so that you know who to go to. If your child, mostly as they get older, says, hey, they're not giving me my accommodations. A child doesn't have to ask for an accommodation. I don't care if they're in high school. An accommodation is the right. They don't always have to ask for it. They should just be getting them. Now, if they refuse them, that's a whole nother story, but that's on the child, then it's not on the school. Like I said before, parents run into problems with like the school doesn't want to update the 504 plan. Put it in writing that you're requesting them to do, you want a meeting to review it. You can just review it and discuss it with the team. So those are like just getting the process started and some of the things that might happen. Like I said, sometimes schools will say, hey, let's have a meeting and talk, and why don't we do some response to intervention and try other things before we go to a IEP evaluation. If you're comfortable with that, you can do that, but they cannot deny you a special education evaluation if you put it in writing. And if they do, you can file a state complaint with the Michigan Department of Education, and I'll talk you through that in a little bit. So don't let them, if you have feelings that you know your child needs help, whether it's a 504 plan or a special education IEP, don't let them talk you down from it. You're the child, you're your child's best advocate, and just know your rights. For the IEP, as I mentioned, you're going to email the supervisor or director and request an evaluation for IEP. Make sure it's written. Make sure you tell your child's name and date of birth, kind of have any pertinent information that you want to share at that time with them. That's very helpful. Once you request it, the school has 10 days to have a review of existing evaluation data. So it's a meeting. It's going to be there's going to be paperwork. There's lots of paperwork in special ed. And they're going to talk about, have they been evaluated before? What reports do you have from your doctor that you can share? And so that's all part of that meeting. And then after that meeting, they have 30 days from the date of that meeting to complete their evaluation, 30 school days. So just know that they sometimes will come to you for an extension, and that just happens right now, just based on the staffing at schools sometimes. So if you're okay with a 10-day extension, it's not a big deal. It happens all the time. I've seen it happen a lot. During that evaluation, most of the time they'll be evaluating them at school, but there'll be things they send home for you to fill out. They may ask for some things from the doctor. So just be ready for that. It's a process. So make sure you're aware that they're going to need you to help them. So you request a meeting to get your child evaluated, which is called the reevaluation, review of existing evaluation data meeting. And then the evaluation will occur. Then they will have a multidisciplinary evaluation team report. And that report decides if your child qualifies or does not qualify for special education. So they will hold an IEP and either say they qualify or they do not qualify. Okay. And I'm going to talk about it a little bit more in a minute, but if they don't qualify and you disagree Like you can see there's some scores that's low and you feel like, I feel like my child should be getting special education services. You have the right to request an independent education evaluation. They call it an IEE. You have the right to request it right then. Then you and the district will agree on outside agency to conduct this evaluation, and it's all paid for by the school. It is no expense to you. You can do that. I don't even know how many times. Maybe I haven't gotten into that deep because we haven't had too many that have done it too many times. But I believe it's every so many years you can request an IE if you don't you disagree. So just once again, remember your rights. Ask questions. Like if you're going through the process, especially with an IEP, they're using all these big words and terminology. It's okay to go, okay, time out. Can you explain that more? Walk me through it. And with an IEP, and even on the 504 sheet or the paperwork, there's a part where they want to know your concerns. You make sure you tell them your concerns and you make sure it's in that document. Because if you ever say they're not doing something or they didn't listen to you, if it's in that part of the IEP or the 504 plan, then you have proof that said, hey, I mentioned that he has some speech and language problems and you didn't do a speech and language evaluation. And so then you have that to back you up. So come to your meeting ready, be the advocate, write down everything you want to say before you get there, because you're going to get there. And some of them are very intimidating to parents because there's a table full of people, right? And they're all there for the betterment of your child. I mean, I believe most schools want to do what's best for kids. But as a parent, I sat in on the other side for my nephew one time who needed an IEP. I know how that can be very intimidating. So I recommend to all parents, get all your questions written down before you go into these IEP or 504 meetings, just so if you get upset or you're confused, you can keep your track of what you need to ask or say.
That is amazing. Help. So practical. And again, just to let people know that they have a voice and also a process, right? There's a typical process, but if anything goes awry, there are other things that can be done to turn that around, right? So again, back to your empowerment, which is wonderful. Sometimes, alongside these school-based evaluations or, those outside evaluations, are there other sorts of assessments that can be used in that? I'm sort of thinking about like neuropsychological exams at times that may happen on the physician side that may have been prescribed, I suppose is the right word, for families. Can some of those outside assessments be used in this consideration too?
Yes, definitely. Mostly during that the review of existing evaluation data. Any reports you have from your doctors need to be shared that. The school has an obligation to consider, and the word is consider, outside evaluations, even when they're doing their own evaluation. So all those reports should be given to the school. I recommend it in an email so you have proof like, hey, I emailed it to them on this date. Or if you hand them a copy, I would then do an email that says, just verifying that you received the evaluation from Dr. So-and-so. Any assessment that you have taken your child for outside of the school, you need to share. And remember, and then doctors, whether it's a psychologist, a psychiatrist, a child therapist, some of our kids need that. They have ideas and suggestions. Schools don't have to do all of that. Okay, schools have the right to go, okay, some of those aren't appropriate for the child's grade or so on and so forth. And a doctor sometimes will word it like, you need to go get an IEP for your child. This child needs an IEP. Regardless of that, the school has to do an evaluation and determine if they're eligible. Always remember, a doctor gives a diagnosis, a school gives an eligibility. So they're different. We have a lot of times where kids come in and they're like, oh, the child has this, but we test them and we're like, well, we don't see it. And they have to meet certain criteria. We have forms that they have to meet at the federal and state level that they have to meet. And we all have to sign to say they've met them. And sometimes doctors will just put that. So parents think they're automatically going to get an IEP. That is not true. But the more information from the doctors sometimes is helpful. Like one of my children had a really big, psychologist or psychiatrist, I can't remember, had written a really nice report and had a bunch of accommodations. Most of them were really great ideas. So, and he knew the child better than me at that point. So of course we incorporated them. But things like a one-on-one aid is one that sometimes parents come in with, and most schools don't like to do that. And there's a lot of research that says that's not appropriate. Maybe I think of a child with epilepsy who's having seizures all the time, maybe for like field trips or something like that, I could see it, but not from day to day. So just because doctors assess them and do all those things doesn't mean the same thing is going to happen at the school, but you need to share all those things during your evaluation, and you can even bring it right away to the schools and share it with them. If a parent didn't know these things and a parent brought these reports to the school, schools have an obligation with child find that they should be at least considering evaluating the child, because if they don't have a form that says they thought about it, the child fine can come back and give them a violation, that they violated the law. You knew this child had something going on and you have this doctor's report and you guys didn't do anything just because the parent didn't ask. The school has some obligations there too, but always share all those assessments. And like I said, schools consider them. So if they talk about in the reports, that's them considering it, and they don't have to do everything in that the doctor recommends per se.
Love, your tremendous suggestion of just putting everything in writing, right? Once you have this meeting, you can write a summary from your own perspective, and say, is this a good summary according to what you all remember? All those kinds of things, because there's a paper trail, which is really, really important, right?
Yeah.
And all the things you just said are really a perfect segue to my next question. So I'm wondering, based on your experience, what are some best practices that can help parents, caregivers, educators, physicians communicate effectively when they're creating and then, of course, implementing things like seizure action plans, 504 plans, IEPs? What are some of the best strategies for communication?
Once again, like I'm going to reiterate, I would do everything in writing. Schools are not allowed to talk to your doctor, obviously with HIPAA and both ways for schools, for confidentiality, and doctors. There are forms you can fill out that would allow the school psychologist, while they're testing your child, to talk to your doctor. I highly recommend that. If you're comfortable with that. Most parents are not. Some parents don't want to share that kind of stuff, but that does help. And it just, best practices for me is everybody working as a team. I hope that most of you have the experience that your school does want to work with you and does want to do what's best for your child. I feel like most schools I've worked with have, even some of the state complaints I work on, there's a lack of communication, or the parent hasn't worked enough with the school and just went right to a state complaint. So always utilize everybody in the school and make sure that you're communicating with them as much as you can. And once again, putting everybody involved in your meetings and make sure everybody's told about it. But best practices is always, being very clear. I always say clear is kind, unclear is unkind. Let's be really clear with them. Talking to them about what your concerns are, sharing everything you can, and making sure you know your rights. Once again, going to that Michigan Alliance for Families and just understanding all those things. And don't get discouraged when you get confused during the IEP process. That's when you can always use the Epilepsy Foundation. They have my email. I have talked to a couple parents before that needed a little guidance during this, during their IEP or their evaluation for special education. I was happy to help. So just use all your resources too, to make sure everything is being done correctly and for the best results for your child educationally. We just want every student with a disability to be successful in life. And then further on, like once again in college, and making sure they're successful there, and teaching kids how to advocate. Once kids get to middle school or high school, our goal is to get them to be their own advocate. And if they're comfortable enough, every child's different, but if they're comfortable enough, I want them speaking up for themselves. And typically, if their child has an IEP, they start inviting them to the IEP meetings as they get into middle school and high school. So then the kids are involved in that process. And I think that's a great thing. So, and you can always, if you're going through the IEP process, and you're concerned that they're not doing what's best, you can also get an advocate through the Michigan Alliance for Families. An advocate will come to your meetings with you, even if it's virtual. Sometimes it's easier to do it virtually because they can be all over the state. And they'll advocate and make sure that school is doing what's best, and they know the laws really well. They know the special education laws, they know the 504 laws. So don't be afraid to bring an advocate. Parents brought them all the time with us, and it was fine. I was actually, when my nephew was getting an IEP, I was basically my brother's advocate. I was there making sure they were doing what's right for him. So know that you can also bring an advocate to any and all of your meetings, and they can be part of your IEP process if you're confused or feeling overwhelmed. There is help out there through the Epilepsy Foundation and through Michigan Alliance for Families. So you're going to feel discouraged sometimes. We've got support for you to help through this whole process.
Absolutely. And I love that teamwork approach. I mean, I always think it's best, as much as it can be done, to assume positive intent and just to know we're all on the same team here, wanting the same goals. And when conflicts arise, there are ways to be good advocates and processes in place. And hopefully it doesn't come to that. But when it does, that's another question, is when there are these disagreements between the school and family members, what are some of those options available to resolve those conflicts? I wonder if you'll walk us through that.
Sure. So make sure you're going through the proper things before you do this. So if you don't, for a 504 plan, we'll start with the 504 plan. If you don't feel like your child's accommodations are being given, say they're gone for 3 days because they had a seizure, and for if they're gone 3 days, they get 5 days to finish their homework, because we know after a seizure, it can take days to recoup. I know my daughter's boyfriend gets horrible headaches, and it takes him many days to recoup. So making sure that, and then the teacher's like, oh, he didn't get that grade because he didn't turn it in on time. You need to make sure you start with a teacher and you CC the principal and you make sure it's corrected. If it's not, I would CC all of them, as well as your superintendent, saying, seeking to understand why my child's 504 plan that says this is not being done. Please advise. If you're not getting an answer and they're still not changing anything, when you have a 504 plan and you want to file a complaint on a school, it's through the Office of Civil Rights. So you go on their website, there's a place to file a complaint, and you can mention, you can just say to them, I'm not happy with this outcome. I'm going to go ahead and see about my rights through the Office of Civil Rights. Schools do not want OCR coming to them, because with OCR, when you file a complaint for that one accommodation for a 504 plan, they come and look at everything in that school and make sure it's lines up with the Office of Civil Rights. Are your doors wide enough? Is your playground accessible for everybody? They look at everything. They don't have to just look at the one thing. They'll look at that one thing and a bunch of other things. So schools really don't want OCR coming. So you could just say, thank you, I appreciate your help. I'm not feeling like his 504 plan is being done. I'm going to talk to Office of Civil Rights, and just say it to him, clear as kind. Like, I'm not feeling like this is being done. So that's a 504 plan. Now, with an IEP, once your child has that IEP, you can file, there's a couple different processes you can do. If you don't think they're getting the help they need or their accommodations when they have an IEP, you can file a state complaint, which is what I do. So you just go onto the Michigan Department of Ed, there's a place to file a state complaint. You fill out some forms. If you have an advocate, sometimes the advocate does it for the parent and can help with that process. You want to be really specific about what part of the IEP they are not doing. If they are not implementing the IEP, use those words. My child's supposed to get resource room help for our kids that need even more help, that are having active seizures. A lot of times they might get pulled out of the classroom and go to resource room, but they're not getting pulled out of the classroom, and you know that. You can say, my child is not receiving their services as spelled out in the IEP. The school has to be doing what's in the IEP, and you can file a state complaint. There's also something called due process you can file, where you kind of get with a judge and there's two sides and a mediator, and then you talk about your sides, and then they can settle that complaint too. So it's your choice. Now, with a state complaint, what typically happens is the state, us as investigators, we have to decide who is at fault, and then if there's a violation of a law. And if there is, we give the school a correction plan. It's one of the things I like about what I do for the state of Michigan, because I help schools improve their special ed programs and make sure they're doing what's right for kids. And there's times there's no violations, and there's times that schools are giving violations. So know that you can do that. It should be your last resort after you talk to your team. I never like when I'm interviewing parents for a state complaint and they say, I'm like, and I ask them about their communication with the principal or teacher, and they never did that. And the district we interview also, and they'll say they never talked to us. We could have handled this before a state complaint. So please make sure you start with the teacher and then go up that ladder in the district before you decide to do that. But once again, just make sure you're really clear with them and you're just constantly communicating with them and sharing your concerns. And once again, putting it in writing, because then what happens is when you file a state complaint, you give us all those emails and we can see, look at this parent did this, this, and this, and the school didn't change anything or do anything. So as a parent, once again, you have all the rights. And some kids will have a bunch of accommodations and the teachers are like, oh, they don't need all of them. They don't get to decide that. You guys decide as a team if they need it or not. If there's an accommodation out there that they grow out of, that's great. But the teacher doesn't get to just say, I didn't want to do that. That's not okay. So they should be able to provide you with some data that says how often they're using these accommodations and so on and so forth. Mostly if it's like a daily accommodation of sitting closer to the teacher or so on. So make sure you ask for those. You're like, oh, so how are accommodations and who's keeping track of that data? Use the word data all the time because they should be. Data is what drives all our decisions in these team meetings. We can't just make a change to any IEP or any 504 plan unless we have data to show why we're changing it. So make sure as a parent, you can say, what data do you have to support what you just told me? And if they don't have it, they're going to have a hard time denying what you're asking. So make sure you know that.
Oh, absolutely incredible. And I'm just thinking about the power of voices and advocacy and also community, right? Because these laws and rights are put into place because we have had amazing people in the disability community who have fought for them, and they are here for us, and that we can continue to hold ourselves and other people accountable to these and create the most inclusive environment possible for our children to learn and for all people to really thrive. And so, Kelly, I can't begin to tell you enough how practical and helpful this has been, but also how energizing it's been today. And please know you are helping many families who are watching this, first and foremost this year, but I think honestly for years to come, that this will continue to be used and distributed and really help people feel a lot of confidence moving into the school year. So thank you so very much. Any other last things you'd like to share with us?
I mean, the last thing I do want to share is as my daughter's boyfriend gets older, I did realize through the university and my work there that the Disability Services of Michigan is also another great resource as he's in the college years. They can help with finding a job, making sure you're not being discriminated against at your job. The gentleman that came to talk to us talked to me right after he had just had one of his seizures. So in my mind, he was there for a reason. He was there for me. But I wanted just to make sure, that like Brendan is his name. I want to make sure Brendan knew that this Disability Services of Michigan exists for him now as he's an adult. And they have tons of resources. They can drive you when you can't drive. They can help you with transportation. They can help you figure out all those things. So there are resources out there, but sometimes parents don't know. So Disability Services of Michigan, I just want to make sure everybody knows about that too, as your child gets older, and to make sure, and mostly in the college age, make sure that they know about it and they utilize it. And you can find that phone number right on the web. So, but thank you so much.
Incredible.
I love talking about this stuff. Brings me joy. I love sharing this because I want all parents to be empowered and all students with epilepsy to be empowered and know that you have rights. And there's people out here to support you and make sure that you get the education you want, regardless of your epilepsy. Like I'm going to be driving my daughter's boyfriend to school because I was like, no, we're not doing that. You're going to go and finish your degree at college no matter what. So it takes the team a little bit, but that's okay.
Well, this gave me joy too. And I just have this feeling that people are watching going, yeah, me too. I feel joy right now. So thank you very much, Kelly. And just know that Kelly is here. We are here at the Epilepsy Foundation of Michigan. If you have follow-up questions, feel free to reach out to us. Thank you, Kelly. Amazing. And now I'd like to invite to the screen Jasmeen Khilji and Burge. And they're going to talk about their daughter, Paloma, which I'm so grateful, and just sort of the experience and journey that they have been on, both with school, but also in thinking about like testing for college entry exams and all of that. So welcome, Jasmeen and George.
Thank you so much, Renee.
Yeah,
we're so grateful to be here, and
we're grateful for you.
With the Epilepsy Foundation of Michigan and all the support, and just listening to Kelly, definitely a lot of the expertise and her experiences she's shared resonated with us, as I'm sure as we start to get into some of our experience, that a lot of those same themes appeared with us as well. So just wanted to say off the bat, thank you so much. We're so happy to be here. Grateful for the opportunity.
Thank you.
Incredible. Well, we're grateful for you too, and your voice and your perspective and just lived experience. So wondering if you can tell us a little bit about Paloma and what are some of her interests and of course plans now that she's graduated from high school. I know you're very proud. I am too.
Oh, well, thank you. Thank you. Yeah, so Paloma is our only child. She's 18 years old. She just graduated from high school, and we're very happy to say will be close to home at the University of Michigan. I think we're extra proud and happy for her because she was accepted into the honors program. And so she's in this very small program, which will take a big university and make it much smaller for her. And so we're very excited. She is a violinist. She started playing violin at the age of 3. She also played field hockey in high school. She was a defensive player, and she's, by all accounts, a very happy, energetic, normal teen, which we're so grateful for.
Love that. And I'm wondering if you can share a little bit about Paloma's epilepsy journey and when she was diagnosed, how did that go and how has that impacted her daily life and education?
Well, Paloma was diagnosed at the age of 4, almost 5. She had her first seizure actually on Thanksgiving morning. I happened to wake up and saw her what looked like to me having the seizure. Shortly after that, we did receive the diagnosis that indeed she did have epilepsy. She was diagnosed with benign Rolandic epilepsy. And shortly thereafter was put on medication that she took twice daily, starting at the age of 4. And by all accounts, I think, we've been very fortunate. Her epilepsy has been controlled because she's been under the care of a great doctor and she's taken her medicine. But we have also seen that, she would get a lot of headaches. And, that the medication would make her a little tired. Not that it took her longer to process anything. She's always been a very strong student, but I think that the medication did affect, I think, her ability to really focus for long periods of time. And so, that's kind of where she was in her academic journey with that. Socially, I think she was a very happy, thriving child and then teenager. But I do think that there were times where her friends didn't quite understand, what is this epilepsy? And we've never seen you have a seizure. And why can't you stay up that late? And there was one occasion actually during her childhood where the entire class was invited to a haunted house. And as you are well aware, those types of lights, strobing lights, can trigger a seizure. And so Paloma stayed outside of the house or the haunted house. And so there was some of that, where she felt apart from her classmates and a little indifferent. And then, there was teasing involved and all of that. But other than that, we were very lucky and very fortunate, blessed that she was able to persevere, make it through school, and then on to high school. And I think that's where our next conversation will take us.
Yeah,
our
amazing.
experiences there.
Very good. Yeah. And I wonder what were some of those first steps you took to secure accommodations for Paloma during high school? And What were some things that went well? And then was there anything that needed some problem solving?
Well, so I think as we started thinking long term about Paloma and going into college and well, specifically first into high school and we knew that the curriculum would become more difficult and the stress of that and the impact that stress and late study nights have on epilepsy. George and I started to look into start having an accommodation plan for her. And our daughter attended a very small private high school in Michigan. And while the school was very open to having a conversation with us about Paloma, there were other children in the school with accommodations. I think they were a little taken aback that, why is this student of ours who's pretty much a straight A student, why does she need accommodations? And that's where the struggle began. And that's when we reached out to the Epilepsy Foundation of Michigan because I think we needed the advocacy, the support, someone who had the vernacular to come in and say, well, I think you should understand as a school, as an administration, that these medications can adversely affect the way or impact a child's ability to study, to focus. And Paloma can't stay up all night studying for tests. It's mandated by her doctor that she goes to sleep early because for her, and specifically the type of epilepsy that she has, where her seizures occur as she's waking up, can most likely be triggered by a lack of sleep. And so I think the real crux began when we went to the school to ask them for this accommodation plan. And the school then took our information to an outside, I guess, board for an evaluation of Paloma. So they took her records, her school records, and this outside board outside of our school, they determined that Paloma wasn't eligible for any accommodation plan.
Right. The private school experience is a little bit unique because I think perhaps legally they are under different rules. I know that at the time they had taken money as a school, some of the financial benefits from the federal government that were distributed as part of the COVID relief. So that may have brought them into more of the IEP 504.
For sure. Yeah, you have to
but
really be in alignment with federal laws around these things. Absolutely. Yeah.
Yeah, but it was definitely I think that the school, to give the benefit of the doubt, I think the school was definitely trying to do the right thing, but I think that they were themselves, maybe because it was so small, because it was a private school, they may not have had the experience that maybe a public school would have, where they would have an in-house expert that done this type of thing before. And so because of that, that's why I would say certainly having Renee, the Epilepsy Foundation of Michigan, like Kelly was saying, reaching out to all your resources. You can't always take the first no for an answer and just say, well, unfortunately, that's it. You got to keep doing your research, just keep advocating,
Well, and I think what you mentioned earlier was educating the people at the school who were in power. And I think once we did that, they were very receptive.
Educating them on epilepsy generally, and then also specifically some of the symptoms of taking the medicine.
Yes.
Just the condition itself, right? It's not going to have maybe some of the same. It's not always going to present for every student, but that doesn't mean that your student is not worth, or that your student wouldn't be eligible for some type of accommodation. And so ultimately we did receive an accommodation plan. So they did, they didn't go, it wasn't technically a 504 plan or an IEP. It was sort of informal, I guess you could say, through the school. It was a formal plan, but it wasn't under those sections of the law.
But I think an important aspect of that is and regarding advocacy is that the plan they put in place. And so I would urge people listening is get everything in writing. And I think Kelly even mentioned that too.
Yep.
So we did have an action plan. We had everything in writing of what Paloma was, and it turned out to be very similar to a plan that she would receive had she gone to a public school.
Exactly.
And
I think it's important to name, like, kids who are in private schools have legal rights too, right? And you're right, though, that there may not be those in every system. Well, they should be connected to one some way or another, but these kinds of special education, roles that are connected through the public health system, or through the public education school system too, like there are ways and routes for private school students is what I'm trying to say, and that they have legal rights as well. It's just really important.
Absolutely.
Thank you. Amazing. Can you just talk a little bit about what it felt like to be advocates for Paloma and ensuring that her needs were met, and strategies maybe that you found most effective?
Oh, I mean, I think, as a parent, we all want the best for our child. And it felt like, of course, I wanted my child to have the same opportunities as every child. And so having a place like the Epilepsy Foundation of Michigan, though, I felt more supported in that role. And because I do think you can feel often alone, that somehow, we're the only parents, going through something like this, or and I do think that as Kelly also mentioned, every child's path and journey with epilepsy is different, and all of their needs are different. And so coming to school and having to explain, while they've seen other children with epilepsy, well, why didn't they need a plan? So why does your child? And you can feel a little bit alone, and while at the same time you have this goal of, I really want to win this for my child. My child is deserving of this. And so while it can feel a little isolating, it's 100%. That's, I think, the biggest thing we learned is it is actually the complete opposite of that, is where so many people willing to help, and the school was willing to help.
Mm-hmm.
And I think the school, they do want to help. They do want the best for their students. And I think with that mindset of you're actually not alone, and the school is most likely on your side, that it's a lot easier to advocate than we think it is.
Oh, I love that. And just that there are ways of being in communication where we can all be learning from each other, right? Like as parents and caregivers, we don't have the educational expertise, most of us at least, but also those educators don't have the expertise of your lived experience, right? And so any way that we can come along and do that shared education ultimately to bring our kids to the best possible place for their own education is a wonderful thing. So good. I know you also had to do some advocacy when Paloma needed to take the ACT. So what was that process like, obtaining accommodations for Paloma, and any significant hurdles you had to overcome in that process?
Yes, yeah. Well, that ended up being another hurdle. I think where the miscommunication happened is you have different parts of a school. You have the administrators, and then you have the high school counselors. And while you may have this document that says my child has an accommodation plan, the school counselors may not totally be aware, at least in our case, an academic counselor, of exactly what the accommodation plan provided. And we found that when Paloma was applying for the ACT, that or let me back up a little bit. We wanted her to receive extra time on the ACT, and the number one thing or requirement is that you have an accommodation in place at least 2 years prior to applying for this ACT accommodation. And she had that. We supplied the documentation, and she was denied. And we
didn't receive the
notice. We were blindsided. We thought, well, we provided the doctor's letter. We, provided the accommodation plan from school. What exactly happened? And so, we actually took the school's word for it. We thought, well, she was denied. But as we began to think more about it and think more about advocacy, and there's something else we can do here. It just wasn't sitting right. And I think that's another message to parents is, if something's telling you that it's something's off, something's not right, it generally is. And I think that there's always room to make a case, even if maybe it's a slim chance that will actually happen. And so we actually called the ACT ourselves, found out that there was this letter detailing these other documents that they needed. And at that point, I think we were a little shocked because we thought it had been handled with the school.
Right.
Once we received that information, then that's when we contacted the Epilepsy Foundation of Michigan again. Renee answered my call and helped to guide me and come up with the correct language to put in letters, because the ACT in of itself is its own, I guess, tangled web of requirements and documents needed to make that case for extra time on the ACT. And once we were able to work with our doctor, Epilepsy Foundation of Michigan, we then educated the school counselor on all of these requirements and documents needed, and went so far as to draft letters for her to send to the ACT on our behalf.
No, Jasmeen was incredible. I mean, she really took the bull by the horns, and the ACT process itself, I'm personally a trained attorney. I'm not practicing anymore. I'm like a recovering attorney, but I myself found it quite confusing, the language on the website, and Jasmeen really took the time to really break it down to try to figure out what exactly was needed, and then did the investigation as well to find that there was this letter that we had not received that was spelled out what the ACT was looking for. So I think there was a number of takeaways. Number one is going back to just like when you hit those road bumps, don't necessarily give up. There's probably a way to work it out. And don't necessarily just rely on someone else to think that they're gonna, advocate fully for you. Like in this case, I went to the school kind of just accepted the no. And then if we had just said, okay, well, that's the answer, that would have been the end of the story. So just that additional effort continued to, and a lot of it, again, could be just the lack of experience at the school because it was small. Maybe they hadn't done this before. So, and to give them, the benefit of the doubt too, like the rules were very, from our perspective, very confusing. So, again, so many of the themes, right? Reaching out, don't give up, right? There's probably a way forward. There's probably resources out there. I'm sure, we would be happy to speak to other family members that are going through it. Like if they want to talk about, we can pull up our file and say, okay, well, this is how we answered this part of it, or that type of thing. We'd be happy to serve,
Absolutely.
in that capacity. So.
That's incredible. And it's such a kind offer. And I just want to say, I'm so impressed with you all and with Paloma. And I just find myself thinking about, we need advocacy in those moments that are uncharted, right? It's like, okay, wait, maybe the school hasn't done this before. Maybe we haven't done this before. We haven't had a student just like this before. And we also need each other, right, to kind of guide through that process. Wait, someone has done this before, and we can help each other in that. And so just wanting everybody to know you have that unique charting a new way voice, and you also have help. So that's what I want people to know when they leave this session, like you've got a voice, your child has rights, so do you, and you are not alone on this journey. So I want to thank you so much, George and Jasmeen. You're incredible. I also want to thank Kelly for being with us today and just the tremendous expertise that you have all brought, lived experience you have all brought, and ultimately love for students and love for the epilepsy community. And it just really shines through. So Can't thank you enough. And as we move forward into our last session for the day, we want to be having every student, every person with epilepsy living their best life. We want people to be able to move and thrive in the community. If people need supported living, we want them to be able to have it. If people are going to school, we want them to thrive. If people are looking for education on the other side or looking for employment on the other side of education, looking for opportunities to volunteer and to live their hobbies. We want everybody to have those opportunities. So we're going to talk more about transition and moving into adulthood. So stay tuned with us, and we'll look forward to the next session. Thank you so much. Take care. Hello, friends, and welcome to our final session for our virtual on-demand back-to-school conference. This one is entitled Building Independence, Transition Planning for Students with Epilepsy. And once more, my name is Renee Roederer. I am the Senior Director of Programs and Community Care at the Epilepsy Foundation of Michigan. And I'm so excited to introduce our next three speakers who will each share with us about transition, discussing practical strategies and resources aimed at navigating the healthcare transition from pediatric care to adult care, and we'll consider how to foster independence in vocational planning, life skills, and setting goals for the future. So I'd like to introduce Dr. Seth DeVries, epileptologist at Corewell Health, Helen DeVos Children's Hospital, who will speak with us about healthcare transition, and Tiffany Burge, educational advocate from the ARC of Midland, who will speak with us about transition planning through the Individuals with Disabilities Education Act and setting goals for adulthood. And Kristen, Reese, family outreach analyst with the Family Center for Children and Youth with Special Healthcare Needs, and mom to Kylie, who has Rett syndrome. So she will give a parental perspective on this topic as well. Thank all of you for joining us, and we're going to start with Dr. DeVries. Thanks so much for being here today.
Oh, yeah. Thank you. Thanks for having me, Renee. Yeah, well, let's jump right into it then, huh? Thank you all so much for this opportunity to speak. Again, my name is Seth DeVries. I'm one of the pediatric epileptologists at Helen DeVos Children's Hospital, and been invited to be here to talk about kind of the medical side of building independence and transitioning our students with epilepsy from that pediatric side of things to the adult side of things. So when taking this into account, first of all, I have no disclosures. I'm going to start by talking about a few things. First of all, why do we transition from pediatric to adult care? Then we can go over some of the barriers that might show up in that transition from peds to adult. And then how do we make that transition happen? So why do we do it? Well, if you look at the numbers, one of the things is the sheer number of pediatric specialists compared to adult specialists as a whole. For example, looking at the total number of board certified physicians, we have, nearly slightly over 50,000 physicians in radiology, for example, right? 30,000 in emergency medicine, and then all pediatric subspecialties, all of them, barely over 20,000 in the United States. So there are just not enough pediatricians and pediatric neurologists to go around. We need to make sure that we are taking good care of our patients, and we need to make sure that our patients are being successfully and effectively transitioned and handed over to our adult colleagues for all of that. Break that down a little bit more just from an epilepsy perspective. In 2022, a study was done looking at the epilepsy centers and the growth of those centers over time. And happily, pediatric epilepsy centers have continued to grow. You can see in 2012, compared to 2016, compared to 2019, the pediatric centers have continued to grow and to build. but they still are significantly fewer compared to the adult population. So when it comes down to it, when our patients become adults, they need to move on and successfully transition to an adult organization, an adult group. The toolkit was provided and put together. And one quote that I found was very interesting. All youth and young adults should receive healthcare transition services starting in early adolescence and pediatric care and continuing into young adulthood and adult care as recommended by the American Academy of Pediatrics, American Academy of Family Physicians, and the American College of Physicians. Yet the 2017-2018 National Survey of Children's Health found that 81% of youth with special health care needs and 86% of youth without special health care needs are not receiving such services. That's a big deal. That, the vast majority of patients, of young adults, are not given any sense of a facilitated guidance in how to make that transition happen. Now, there's a lot of reasons for this. There's a lot of barriers. And some of those those barriers could include gaps in communication or gaps within the consultation, training limitations. The level of training between pediatrics and adults, the level of training is the same, but we're trained in different things. And so there are times when an adult neurologist might not be as familiar with some of the complex pediatric epilepsy conditions that could be out there. The care of delivery, care coordination, support staff, lack of care coordination and follow-up. It seems like there can be a significant gap there between how care and coordination works on the adult side compared to the pediatric side. Concerns for mental health supportive services. The adult center may be less familiar with the resources for young adults with chronic conditions. Perhaps there is a limited level of availability with social work or with coordination, care coordination. There's lack of patient knowledge and engagement. When you think about an adult neurology office, you might not be thinking about the young adults. You might be thinking of, the older patients. And so how much involvement do young adults have? How much advocacy, self-advocacy do those young adults have? And then lack of comfort with adult care. And I see frequently that level of barrier oftentimes comes more from the parents than it does with the patient. The parents have been taking care of their child for a very, very long time. Now it's time to move on to take care of for the child to take care of themselves. What is that going to feel like? Are the parents ready for their kids to leave the nest? So all of these factors, barriers that are out there, these factors that can influence the transition, including the diagnosis, the complexity of the diagnosis, state, federal guidelines. What do the reimbursement look like from a medical standpoint? How much time does it take? The staffing, patient support, administration. Where are we going to do this? What's the location? All of this stuff needs to be considered when we are working and facilitating for a good transition from the pediatric side to the adult side. And that seems daunting at first, but happily, there's a wonderful resource called Got Transition. So gottransition.org has been extremely involved. This is the big push for making that transition happen. And so what does that look like? We think about the 6 core elements of transition, and that includes policy, tracking and monitoring. It includes working on readiness with our patients, planning that transition, actually making that transfer of care, and then transition completion. And this process for us starts as early as 12 years of age. We think about, at around 12 or 13, 14 years of age, we are going to go over that transition policy, talking to our kids, talking to the parents about, hey, you know what? Yeah, it might feel like a long ways away right now, but 5 or 6 years are going to come faster than you think, and we need to at least start thinking about considering what that's going to look like when you are 18 years old and ready to transition to an adult, to the adult side. Tracking and monitoring, tracking the progress and continuing to work on that oftentimes is a lot of work that happens behind the scenes. But then as we think about transition readiness at around 14 to 18, planning that transition and then making that transition, all of that stuff happens, and it happens pretty quickly. And when there's a level of dedication to the process, it happens very smoothly. For today's conversation, I want to concentrate on points 3, 4, 5, and 6, that transition readiness, transition planning, transfer into an adult-centered care, and then transition completion. So transition readiness, what does that look like? Oftentimes what we do in our clinic is really go over a lot of questions with our patients. And this doesn't take too much time. It takes just a brief amount of time to ask a series of questions for our patients. And depending on how old that patient is, it's going to have an impact on what questions we're going to ask. For example, when our patients are 12 years old, we're going to be asking questions like, well, do you even know the name of the medicine? Do you know when you take your medicine? Do you know if there are, do you know how to call the doctor in case of an emergency? At 15 years of age, we might be asking a few more questions. In addition to what is your medicine? Well, what is the dose of your medicine? How do you monitor your medicine? How do you monitor your diagnosis? How do you, what type of tests might you be thinking about for your diagnosis, like an EEG or an MRI? At 17, we're getting a little bit more, and now we're going to be starting and asking our patients a little bit more about insurance. What does it look like when you turn 18? Do you know how to look for things outside of the medical field, like applying for a job, creating a budget, applying for college, or advanced learning? And then at 18 years of age, now the kids, they're not kids anymore, right? And we're talking 18 years old, 19 years old. They're adults, right? You're a grown up now. Right? And so have you had an opportunity to schedule an appointment by yourself? Have you had an opportunity to be in the room by yourself with your doctor? Have you investigated or considered what transitioning your health insurance from your parents or guardians to yourself, what is that going to look like? Now, not everybody is able to answer those questions. Sometimes our patients are going to require help from their parents. And when that is the case, we might be asking a little bit of an alternative series of questions for our parents, aimed at the child or for the child. But now the guardians are going to be asking those questions. The caregivers will be answering those questions. So that planning, so that is all about the readiness. And that gives us an idea of giving the patients and the parents an opportunity to really think about what is it going to look like when we make that transition, right? And then we can start talking a little bit more about the planning. And transition planning really centers on preparing both at the front line and also behind the scenes. What are we going to do? We discussed developing a plan of care, following through with those readiness assessments. We start to prepare a package for the adult clinic. We start to look at the situation to determine what others potential support might we need for that transition. At times, we might be working with a neuropsychologist to assess our patient's ability to live independently, to make decisions independently. Will they require a little bit of extra support with their parents? Would they benefit from power of attorney or maintained guardianship with their parents after reaching the age of 18? And what will that look like for the parents? How will they prepare for that? And then we can start working on that transfer of care. And the transfer of care is a little bit complicated, just in the sense of making sure that we have all of this information ready for that adult clinician to receive, right? So that final transition readiness assessment, the plan of care, transition goals, prioritized actions, medical summary, emergency care plan, all of this information needs to be prepared and ready to go. At times, we might need those legal documents. We might need some additional clinical records. And then we work with our patients and the guardians about making that referral to the adult clinician, right? Confirming that appointment is available, confirming who they're going to see. If we're able, it's always nice if we can connect the patient and their guardians with that adult clinician, and have a little bit more of a kind of a meet and greet, if that's possible. That's something that we can sometimes pursue. It's important to have a prepared letter with that transfer package, providing a brief summary of the patient's history, and then working and communicating with that clinician as a whole to make sure that they are ready, comfortable, prepared for receiving the patient. Once all that's done, that transfer of clinical care can go very, very smoothly for our patients. And then we approach that transfer completion. And transfer completion, oftentimes from a follow-up perspective, we are going to be communicating both with the patients and the caregivers, as well as with the adult clinician. Usually about 3 to 6 months after the last appointment with the pediatric specialist, we can start looking at working with the adult specialist, asking for feedback. How did this work? What information was beneficial for you? Was there anything that was missing? Is there anything that needs to be improved upon, for future patients? That communication as a whole is going to be very important as that transfer process develops, because kids turn 18 all the time. Kids grow up to be adults, and that transition has to occur. And as this completion and reassessment continues to move forward, it does move and build an ongoing collaborative partnership with those adult specialty care clinicians. I have the wonderful fortune of working very closely with my adult neurology colleagues, and transition of my patients from the pediatric side to the adult side has been very, very smooth. And the feedback that I have received both from my patients and from my adult colleagues has been very positive. And providing that nice package of information, reviewing all of that information with the patient and the parents at an early age, moving that forward step by step, every couple of years, going over that information again, reminding the parents what it's going to look like, reminding the patient what that's going to look like, has been extremely valuable for the patients and the caregivers and that adult clinician. in summary, as we pull all of this together, that transition from pediatrics to adult epilepsy, it's inevitable, right? Just like Thanos, it is inevitable, right? But however, early discussion, frequent review, that helps everyone. It's going to help the patient. It's going to help the parents, the guardians. It will help that pediatric epileptologist as they are preparing all of this information. And it's going to help that adult epileptologist. So yes, transition is inevitable. But in the end, our patients, they are prepared, ready for independence and more responsibilities.
Well, that was absolutely excellent. I loved that wonderful ending there. And I just want to thank you, Dr. DeVries, not only for this presentation, but for you and all your colleagues. And I hear so regularly that this transition process is going smoothly. And in fact, we just had a young adult retreat and I asked them about their process, and every single one of them said there was nothing they would do differently because their doctors had prepared them so well. And so I'm very grateful for that. Thank you for your time, and we appreciate all that you're doing. Thank you. And now I'd like to invite Tiffany Burge to the screen for a conversation about transition in education. And so now I'm going to also share my screen so that we can share this presentation with you.
Thank you. Hi, everyone. So today we're going to be talking a little about building independence transition from school to adulthood. I'm Tiffany Burge. I'm an educational advocate with the ARC of Midland. So on our agenda are post-secondary goals, and that would be transition planning from high school into adulthood, student rights, including self-determination and empowering decision-making, college and employment readiness, so some options for after high school, and including CMH supports and services and other skill building opportunities, and then other community supports that may be available, including Social Security programs and DHHS programs. Post-secondary goals are the transition process from high school into adulthood. And we'll be talking a little about the Individuals with Disabilities Education Act requirements and how those must start by age 16 and include the student in the school setting as well as in the community. These goals and requirements under IDEA in the IEP would include strengths, preferences, interests, and developing functional skills for the student for employment and community life. So gathering information about the student throughout that period would include transition assessments, conversations with the student and parents, observations in the school setting and outside of the school setting, work samples, interest inventories, and standardized assessments like career assessments or skills and interest inventories to identify what career paths or secondary, post-secondary education paths might be the best fit for the student. So in those measurable goals would be reviewed annually with the student and the parents, and services identified that would help meet the requirements of education, training, employment, and independent living goals. Those would be updated annually and as the student's interests and abilities become more obvious and focused. Transition services are a coordinated set of activities to help a student achieve post-secondary goals. So they're activities that the student and their community complete, such as teachers, family, service providers. Could be things the student goes out into the community and completes, or things that are done in the classroom. They're based on the student's needs, strengths, and preferences, and could be done in any of these different categories here. Some examples of those transition services could be training, like social skills, learning how to interact in employment, requesting accommodations in a college classroom, education, instruction, and learning how to advocate for oneself in a class or in another setting, asking for differentiated instruction in a certain subject, or maybe even taking a college tour. Employment examples could be learning to read and follow a daily visual schedule, or community work experience, actually going out to an employer. And then those goals would be updated as a team. Some independent living goals could be learning and mastering adaptive switches or preparing meals independently, memorizing phone number or address, or maybe even direct instruction and math skills. So it's all based on the student's individual needs. A little bit about student rights. A student's right to, students have rights to their own self-advocacy. So speaking up for themselves and making their own decisions. And this all begins hopefully before age 18, but by age 18, the age of majority, the student has every right to make their own decisions regarding education, mental health, their living situation, the relationships they're in, their finances and credit, voting, getting an ID, and all male students are required to register for selective services regardless of disability. So we have to start preparing them ahead of time for those rights that they have and learning to speak up and take responsibility for themselves and self-advocate, knowing their rights and how to get help with those things, and communicating their needs. And self-determination is making things happen in their own life. So people who are self-determined know what they want and how to get it. This would involve their work and volunteer activities, daily activities in their personal life, employment, college, supported decision-making. If a student needs help making those kind of life choices that we talked about, they can seek advice from trusted sources and still maintain that autonomy of making their own choices. They can seek that advice of a trusted person in problem solving and also in understanding natural consequences for their own choices. So we don't want to prevent them from making their own choices. We want to help them learn what the consequences of making them are. To take that a step farther, if a student needs more support than just supporting them in making those decisions, person-centered planning can be completed. Person-centered planning can be just a topic we talk about, or it can be an actual official document that's used with different types of service providers. Person-centered planning identifies the person's strengths, goals, choices, needs, and desired outcomes. And then it documents the person who's authorized to assist in making those life decisions. And so again, we're trying to preserve the person's autonomy and decision-making while also supporting them to make good choices. College and/or employment readiness. So this subject area will talk a little bit about paid employment, skill building programs, supported employment, and community participation. So some options for after school. Once a student has graduated from high school or left high school with a certificate of completion rather than a diploma, there are some different options depending on that. So college or technical school, paid employment, and then skill building programs are sometimes referred to as day programs, and they can be focused on skills rather than immediate employment. So someone might learn the skills that would be needed to actually complete the job before moving on to competitive integrative employment. Supported employment is a model of employment with job support, job development, job coaching, and or transportation. So someone might actually go to the job with the person with a disability and support them in learning the skills that it takes to function within the work environment. And then community participation are just opportunities for socialization and relationship building, just inclusive environments in the community. So a little about college and the process of transferring from high school into college for a student who may have a disability. There is no special education or IEP in college. So a student who previously had an individualized education plan will need to transfer that into a 504. In some schools will accept a 504 plan. A 504 is under the Americans with Disabilities Act, and colleges provide accommodations under civil rights laws. So a 504 is applicable. It is a civil rights law. However, some schools prefer that you just register with their disability services department. Most schools do. So the student would be the one who has to register with that disability services department at that individualized college. The colleges will then provide accommodations. There's no case manager and the parent is no longer in the loop. So the student is accountable for maintaining communication with disability services and the professors. There's no evaluations to determine if a student is eligible for disability services at colleges. The student must provide documentation to the services department, and different schools request different documentation. Some may want a recent evaluation from the high school, some may want it from a doctor. Different schools offer different levels of support as well. Some have specific programs for different types of learning or thinking differences, and others will just provide specific accommodations, and then the student is responsible to take that document written by the Disability Services Department to each professor. Another support that is available to students with disabilities is and all adults with disabilities, Michigan Rehabilitation Services, which is MRS, and the Bureau of Services for Blind Persons is BSBP. They're equivalent agencies, so just depending on the disability. They're vocational rehabilitation services agencies for the state of Michigan. They prepare for, secure, retain, advance in, or help people regain employment who have a disability. To be eligible, the disability has to be a physical or mental impairment, and or create vocational or work-related barriers. So there's a program available beginning at age 14 through age 26 for students who have a documented disability in high school or college. They provide early intervention services with the goal of competitive integrative employment, job exploration, and work-based learning. They also do some job counseling and post-secondary education, workplace readiness training, and self-advocacy training. So they try to prepare the student ahead of time before we move on towards college. Michigan Career and Technical Institute. This is a vocational training facility. Michigan is rare in that we're only one of 8 states who offer a facility like this. MCTI provides career development, education, training, and support services for individuals with disabilities. They have 12 different programs, all certification programs where a student can attend from 1 term up to 6 terms and get a certification in one of these different vocations. They provide accommodation services, accessibility features, health services, and job placement services as well. So when a student leaves MCTI, they often have a job or are lined up to have a job. The cost to pay for MCTI is covered through Michigan Rehabilitation Services, the previous agency I talked about. So when a student is in high school, it's important to apply for Michigan Rehabilitation Services. It's just a simple application. It's not based on income or anything like that. If a certain student has a disability and they think they may be interested in some of those career exploration opportunities or an MCTI, they should fill out an application for MRS. MCTI is also ran very much like a normal college campus. They have dorms, room and board is included. They do run on a balanced calendar there. So the students attend for 3 months straight and then come home for 2 to 3 weeks versus a normal college calendar. A little bit about skill building opportunities. Most of these are through the community mental health system. So these are services and supports that are paid for by Medicaid through the CMH system. Supports coordination is case management, respite services, provides an opportunity for parents to have a break. A caregiver will come in and sit with the person who has a disability so the parent or other guardian can have a break. Community living supports are often referred to as staff to increase or maintain the personal self-sufficiency of the individual with disability, to help them participate in the community and also to be productive and as independent as possible in their home and community. And then there's also skill building services, supported integrated employment services that kind of overlaps a little bit with MRS supports, assistive technology and environmental modifications. So if the home or the employment needs some modification for the person with a disability to access it, they can help with that, or also transportation. To enroll for CMH services, a person can go to michigan.gov MDHHS and then follow those drop-down arrows, or the Community Mental Health Association of Michigan also has a directory of all the local CMH counties by county, or you can just Google the county and CMH and it should pop up. Other community supports. So I'll touch a little bit on Social Security programs that may be available for a person with a disability, and also MDHHS service programs that are available. Supplemental security income is, we often hear referred to as Social Security. It's the income-based program that's funded by general revenue for persons who are blind, disabled, or aged 65 plus. They do not need to have worked to qualify for this program. It does come with Medicaid and is a standard monthly amount. The maximum monthly amount right now is $943. To be eligible, the person has to be, there's a determination of disability that has to be completed. And then assets and resources have to fall under resources less than $2,000 and income based as well. So the benefit amount may be less if there's other income in the home or someone pays household expenses for the person with a disability. And then there are some resources that are not counted as against qualifying for SSI. So the home a person lives in, one vehicle, and personal and household goods are not included in those assets. RSDI is another form of Social Security that is available. It's funded by Social Security taxes though. So this amount is determined by the work credits. So how much the person has worked, how much they have earned, or spouse or parent, if it is a child, has earned. It provides income after someone retires or has lost income due to an injury or disability that can no longer work. Does come with Medicare, and benefits are paid monthly as well. To apply for either of those programs, you can go to ssa.gov and then click on whichever one of those three programs. It is recommended that you schedule an in-person appointment. They do have that available, and it is helpful to ask a lot of questions. Only like 30% of cases are approved on the first try, so do appeal if your student is denied. A few more programs through MDHHS, so this is Michigan Department of Health and Human Services, offers home help services. So this provides hands-on help for people who need assistance with activities of daily living or instrumental activities of daily living. It is paid for, again, through Medicaid. So the person must have Medicaid in order to qualify for this service. And then a provider is paid, to provide that assistance. The SNAP program, Supplemental Nutrition Assistance Program, is the temporary food assistance program that we're all familiar with as the Bridge card. It allows people to purchase eligible food items. To qualify, a person must be low income. If they're under age 22, they're grouped together with the family if they live in the same household. So if your student applies for this program, you would want to say that they have a contract that they pay you rent and utilities if they're under age 22. Otherwise, they're considered as a part of the family household. The maximum amount for a one-person household is $291 per month right now. Some expenses are deducted from income, like rent and mortgage and utilities. And a few resources when transitioning from high school to adulthood. The ARCS Center for Future Planning does a great job of supporting and encouraging families to plan for the future. Think College provides resources and assistance for college options for students with disabilities. Michigan Alliance for Families provides information, support, and education for families who have children and young adults who receive special education services or have an identified disability. And then I'm Determined provides direct instruction and opportunities to practice skills associated with self-determination, so in making one's own decisions. Thank you again for having me. I'm Tiffany Burge with the ARC of Midland, and there is my contact information.
That was truly tremendous. Thank you so much for sharing all of those resources. And it's just so valuable to see all of that in one place. And I know people will be watching this again to get that information. So thank you for your time and expertise. I appreciate that so much.
Thank you.
Wonderful. And now I would like to invite Kristen Reese to the screen. And just so pleased to have some time with you today and to hear about your journey and, of course, any resources you may also know when it comes to transition. So thank you for providing a parental perspective as we talk about transition. And I know you have personal stories of these things, and this topic is important to you personally and professionally. So I am wondering if you could just introduce yourself a bit and tell us a bit about your daughter, Kylie, and her diagnosis of Rett syndrome.
Sure. Thank you so much for inviting me to come today. I was really excited and prepared lots of notes. So Kylie is my 26-year-old daughter. She just had a birthday Monday. So it's
happy birthday.
Yeah, 26. So, and she received a diagnosis of Rett syndrome when she was approximately 3.5 years old after about an 18-month diagnostic journey. She started having symptoms around age 2, but prior to that did develop typically, and then suddenly started losing skills. And I'm taking her to lots of different doctors, including out of the state, trying to get answers. And finally, through some genetic testing, was able to identify her diagnosis. So a lot of people aren't familiar with Rett syndrome. It does occur primarily in females and is caused by a random genetic mutation. So nothing in my family history would have, shown up before. And individuals with Rett syndrome are considered developmentally disabled, although there are no true ways of measuring their capacity and intelligence. But they have a lot of different symptoms and characteristics, including gastrointestinal, seizures, scoliosis, gait disturbance, swallowing issues, and my daughter has most of those. So it's rather complex, and she has gone through different phases, but we've experienced all of those things that come along with that diagnosis.
Yeah, thank you so much. And I'd love to just hear a little bit more about, what are some of Kylie's interests, and as she has aged, how have you made space for those for her?
I would say the thing I love most about Kylie is her spark. She has, she is completely nonverbal. She does have some capacity to communicate via an eye gaze device, but that just depends on her mood and whether she wants to be bothered with you. But she just has such an amazing personality. And for someone who doesn't talk verbally, she definitely can get her point across. She lets you know what she likes, what she doesn't like. When she was in school, they used to joke about her being the fashion police, because her teacher would come in and my daughter would kind of give her the, the up and down look, and then she'd either get a smile or a look like, what are you wearing today? So she kind of got the reputation for being the fashion police at school. So, and she's pretty easygoing. She really likes to be around people. She has 2 older siblings. When they were younger, she loved to be right in the thick of things and hanging out with them and their friends. And that has really gotten harder probably with them growing up and, moving on and having families of their own. Not having that continual stream of kids in and out of the house that she could, hang out with. But we try to find things within the community that she can do. Now that she just finished school, you're catching me at a tough time because we're still trying to figure out what that's going to look like as we move forward.
Yeah, and that's just an ongoing process, right? Yeah, that makes a lot of sense. And I know with Kylie's diagnosis, she needs a lot of, supervision and specialized care. So I'm curious, what would you like parents, medical professionals, members of the wider epilepsy community to know when it comes to these kinds of needs, and particularly as youth age into adulthood? What would be helpful to know?
I would have to say that it gets easier and it gets harder.
Yeah.
In the beginning, everything is so new. I really felt like our life was a roller coaster. And trying to figure every little thing out, every new diagnosis that came along with it, juggling, my career and her needs. I was a single mom for most of her life. So it was really challenging. And, as she gets older, you kind of start to figure things out, and then it kind of gets a little easier. But then they're also getting older, and you're getting older, and your body's getting tired. So, things like just giving her showers can be very physically taxing. And so it's like you kind of figure it out, but then it's still challenging in some ways. So it really, and like I said, having a child with complex needs who is more hands-on care it's exhausting mentally, physically, emotionally, not to say a child who isn't hands-on can't be as well, but it's a different toll that it takes on you. And the fight for services never ends. So resources do seem to be harder to come by once they become adults. And you think it's hard when they're kids, and then they become adults, and it's like, wow, the resources really dry up. So
that is such a perfect example of, I think, why we need each other too, to sort of help lift that load for each other, but also do that collective advocacy to really try to make more of these resources available. And so I really thank you and parents who are in that position. And, I want to do all that we can to connect people to each other and to that collective work. So that is great. And speaking of resources, at the Epilepsy Foundation of Michigan, we're always trying to point to resources for people so that they know what is out there. So I'm curious, if you have some that have been especially helpful for you and your family, and also in your professional role, if there might be others that you might recommend.
Yeah, I would say probably connecting to other families has always been one of the most valuable parts of our lives. I can remember when my daughter was, I don't think quite diagnosed, but I had connected to a couple people in the Rett syndrome community. And during that time, well, she still does have sleep issues, but during that time, she was waking up in the middle of the night and just screaming, just hours. And I was so sleep deprived. Like I said, I was a single parent, so I'm trying to work and going through all these things. And I remember connecting to a mom and just sobbing on the phone with her. And I didn't even know her, and her just saying, it's okay, you'll figure it out. We went through this, it got better. Just having people who understand what you're going through. And for what resources are out there, I think parents often share these things with each other more than professionals. And I'm not knocking any of the professionals that have been in her life. We've had some very amazing, very caring, professionals, but as far as having the most valuable impact on our life, I would have to say it would be the information that I got from connecting with other parents, whether it's finding a resource or just a shoulder to cry on sometimes. So another thing, and I'm a huge advocate for this, you can tell, is respite services. and again, it gets harder when they get older to find these types of services. And I don't think it's something that is, wow, super valuable just for parents like me who have a child that, is very hands-on, because even if you don't have a child that's physically demanding, the mental and emotional toll and having those opportunities to truly take a break and just disconnect. Even when I'm home and my daughter's resting, I still kind of got that ear cocked. I'm listening, and having an opportunity for her to be out of the home in a safe environment where she's cared for was absolutely vital to my mental health when she was younger. Because I don't think I could have possibly, gotten through some of the tough times without that opportunity to just recharge, get some sleep. That may be all I did.
Because I imagine just that mental load of knowing all the things that need to be done and paid attention to, and then just the hypervigilance, like you said, of kind of always being on guard. I know so many of our parents relate to that. And I also love what you said about just getting connected relationally to communities and circles of other parents. I recommend that for folks too. And because you're right. I mean, sometimes I learn about resources not from my, education and background, not always from like even my professional organizations, although I also do, but it's often parents who will say, I learned about this thing. And I am so grateful because that allows me to point to that to other people with other people as well. And so I appreciate that lived experience expertise. That's great.
Yeah, you can't find these programs by yourself. My daughter was on the children's waiver program, and now the habilitation supports waiver, and having community living supports was, like I said, I was a single parent with 2 other children. There just wasn't, sometimes I just needed a body, someone there to, help. And I really don't think I could have gotten that program. I had a good friend who was also very much a mentor for me, who really helped me navigate, because those programs are so confusing, and how do you apply and who do you talk to and getting those services. So having that connection with other parents who've done it really helped me a lot.
Incredible. Thank you for sharing that. And I know this is going to continue to be a major focus for us in the years ahead, just because we've heard about some new initiatives out there to really support and shine a light on transition, right? These transition moments to adulthood, and skill building, and finding places to live with supported living. And so we are learners alongside all of you, and I think we're going to have more and more of those opportunities in the next years. So I'm excited to journey together in that. And this year, the Epilepsy Foundation of Michigan, we chose our 2024 Challenge of the Year to be accessibility. And I'm curious, from your perspective, how can schools, medical settings, community spaces make life and participation just more accessible and inclusive for people like Kylie?
Kylie really has some serious limitations in that she doesn't talk because of her syndrome. She doesn't use her hands. Communication can be very difficult. And one of the things that I've worked on very hard with her in identifying adult providers is those that will still talk to her, not necessarily to me, but talk to her. That truly recognize that she's a person. She understands, and while she has some pretty significant communication deficits, she also has a lot going on that she understands, can communicate, can, be a part and be involved in her care. And trying to find, you can tell doctors that, but some really just seem to get it and some don't. So that was kind of one of the things that I've looked for in the medical field, were people who recognized her as a person, not just, oh, okay, mom's in charge, we're going to talk to mom, but truly including her, talking with her, letting her know what's happening.
I love that. Thank you. And as we get ready to close, anything else you would just like for us to know about Kylie, about what's been helpful, or things that maybe are uncharted that could be helpful?
I've done a lot of thinking about transition, and in my professional role have been involved in various initiatives, programs, projects that have revolved around transition. And at the end of the day, I think the thing that I struggle the most with is there is no one size fits all answer. Especially when you're looking at children who won't be independent necessarily. How do you involve them in that process? She's not going to call the pharmacy and order her medications. And that's just the reality of it. That doesn't mean she can't still understand, okay, it's time for your medication, and this is what you're taking, and this is why you take it. So you have to get really, really creative, but that is going to look totally different than a child who will potentially, be in charge of their healthcare. So, I really struggle with that because I felt like I was very prepared and doing all the right things for Kylie's transition. And we had a very long conversation with her pediatrician, who I absolutely loved, had a great relationship with. And she had assured me that she would keep my daughter until she turned 21. Great. You want to plan ahead, but you can't plan too far ahead. So we're going along, and my daughter is on SSDI. Her biological father's on disability, so she's an adult disabled child. I didn't know that came with Medicare after 2 years. Mm-hmm. So all of a sudden, like a month before her 20th birthday, I get a thing saying, welcome to Medicare. This starts in July. And it's like, wait, what? Well, yeah. Don't bill Medicare. Yeah. So all of a sudden, it was like this doctor that I thought we were all set with for at least another year couldn't be her doctor anymore. Yeah, gosh. So, even though you may think you're doing all the planning, sometimes you don't know what you don't know. And how could you? Yeah, exactly. Yeah, how could you? And like I said, and I thought I was pretty savvy in this area, but no one ever told me that. I didn't know. Yeah. So that was kind of a surprise. And so all of a sudden, here we are in crunch time trying to find a doctor. Where do you go to find a doctor that is going to take on a child that's more complex and have a lot of and she's not particularly medically involved, that she's at the doctor a lot, but there's prior authorizations for this, and we need prescriptions for that, and we need, so it's definitely the type of patient that you want the right fit for, in terms of having not only a doctor that understands and can get to know the child and develop a relationship, but has support staff that can provide all of those things as well. Yeah. It just makes me think about the importance of both, parental friends as navigators, sometimes of these systems, but also formal professional navigators who can help people know these steps and what's coming, because like you said, you don't know what you don't know. And there are so many things we don't know until we need to, right? And it's hard to anticipate all of it. So yeah, I admire and celebrate the parents that are really charting that ground, and also, find myself in our organization and with other parents just wanting to come alongside, so people know they don't have to go through that by themselves and don't have to figure out everything as if it was from scratch all the time, right? And can pick each other up in those moments when there is, a crisis or a surprise or an unexpected kind of, bump in the road. Yeah. And turning 18 or turning 20 or turning 25 or 26 when, school, I mean, there are so many transitions that continue to happen. You know, with me having such an important role in my daughter's care, of course, I naturally worry about what if something happens to me? You know, who is going to step in and work with her best interest at heart to really support her in getting the type of care that she needs to be her best self.
Yeah.
And luckily she has an older sibling who has talked about it, but then you have the guilt because she has her own family and 3 young children. And, you know, it's like, oh, I know how hard it's been for me. But, you know, one of the things in this, I guess I can thank COVID for it, but I sat down and finally wrote out a document on her care that talked about every single doctor she sees, why she sees them, what our relationship is like, what they do, when to call them. And it's probably 4 or 5 pages long. And like I said, she's not even particularly medically involved in that she has a lot of medical issues, but there's so many things that I recognize are in my head and nobody else's.
Mm-hmm.
And so I really try to update that document at least every 6 months, if not yearly, so that in the event that someone else needed to step in, they'd have not only the current information, but a little background and a little better opportunity to understand, you know, what's going on.
Yeah, there's some beautiful wisdom in that. I think with everything you've shared, you know, just the beautiful emotions and experiences, the difficulties, the big questions, the kinds that keep us up at night. I have a feeling so many parents are watching this and are saying, oh my gosh, I feel seen and heard because you voiced this today. And so I want to thank you for that. And just to know at the Epilepsy Foundation of Michigan, we can continue to connect people to people. That's what we're about. No one has to go on this journey alone. And so, Kristen, thank you so much for your time and for your stories. Very appreciated. So thank you.
Yes.
And to everyone else, as we prepare to close, I just want to thank every speaker and panelist for guiding us through these next best steps, entering the school year, thinking ahead. And of course, I want to thank the Michigan Pediatric Epilepsy Project for sponsoring today's conference. And more than anything, thank you for coming, for being here, for watching, for all the investment you have in the lives of your children. And thank you for learning with us. And I just want to say, we at the Epilepsy Foundation of Michigan are here for you. We are here to connect with you throughout the rest of the year. And so we encourage you to learn more about our programs, events, and services on our website, which is epilepsymichigan.org, and Michigan is all spelled out. And you can also call us on our Here For You helpline. We're here for questions, resources, or just that listening ear, someone to be present. And that number is 800-377-6226. And so we encourage you to stay connected, get involved, and thank you for joining us, and have an excellent school year. Take care.